Give the heading conjunctiva. Can you please all of you confirm we had to start from here only? Guys, we had to start from conjunctiva. Please confirm fast. Wow, everybody is silent today. Yes, okay, very good. Now I got the message. Chalo, let's start. So you all know that what is conjunctiva? Conjunctiva is a thin mucous membrane on the ocular surface, right? And what is conjunctiva? Just learn with me. What is conjunctivitis? Of course, we all know it is inflammation of conjunctiva. Inflammation of conjunctiva. What would be the signs and symptoms? I last taught you about keratitis, the 5 fingers. The same 5 fingers will fit in. So let us note it like this. Conjunctivitis is inflammation of conjunctiva. Okay. And signs and symptoms are the same 5 fingers. That is pain, redness, photophobia, blepharospasm and discharge. Now again very important here, which type of redness? Which type of redness? This time you will answer it as conjunctival congestion. I taught you about the types of redness. So we will answer here conjunctival congestion. Okay. Then next we talk about is pathologically, if there is a conjunctivitis, pathologically we divide it into two, that is there can be 2 types of reaction. One is called the follicular reaction and one is the papillary reaction. Follicular reaction and papillary reaction. So what is follicular reaction? You all know this is formation of follicles. Formation of follicles. And what are follicles? They are aggregation of lymphoid cells. Follicles are aggregation of lymphoid cells. And what about papillary reaction? Papillary reaction is multiplication of the epithelial lining. So please all of you note down, it is epithelial hyperplasia. Papillary reaction is epithelial hyperplasia. Coming to what is the treatment? So how do you treat conjunctivitis? Acha, before that I need to mention one more thing I forgot. What about discharge? Redness you all said is conjunctival congestion. What about discharge? Now the discharge will again depend upon the etiology. Suppose let's learn it this way. BCVA. Okay. What is BCVA? Bacterial. The etiology can be bacterial or chlamydial or viral or allergic. If it is bacterial, the discharge is purulent discharge. If we learn like this, it becomes easy for us. Purulent discharge. Chlamydial, it is mucopurulent. And viral and allergic is watery discharge. Viral and allergic, it is watery discharge. Talking about next important thing, treatment. How will you treat conjunctivitis? How do you treat conjunctivitis? Again will depend upon BCVA, bacterial, chlamydial, viral or allergic. If it is bacterial, you all know we give antibiotics. Chlamydial, again we give antibiotics. Viral, again we give antibiotics. And allergic, we give anti-allergics. Or we can go for steroids. Anti-allergics or steroids. Okay. So, are we over with the chapter? No, the chapter starts from here. Okay. So, what we have just learned is what is conjunctiva, what is conjunctivitis, How will a patient of conjunctivitis present to us? What is the pathological reaction, and finally what is the treatment? Okay. So once we are over with this, now we come to one by one, we take specific conditions. First give the heading membranous conjunctivitis. Give the heading membranous conjunctivitis. That's comfortable. Okay, so coming back to, yeah, Jammu, where were you lost? Okay, I'll repeat it once again, but let me again repeat this instruction for you all. Whatever questions you need to ask, you will note it down on a paper, and at the end of the session, I'll give you 15-20 minutes to ask me whatever you want to ask. Otherwise, there can be too much of interruption and we will not be able to move further. Okay, coming back to, I will repeat it for you, Jammu. What I said is that what is conjunctivitis? You know. What are the signs and symptoms? You know, these are the 5 fingers. What type of redness? Conjunctival. Discharge will depend upon the etiology. And finally, we talked about that pathologically conjunctivitis is of 2 types, that is follicular and papillary reaction. Okay? Follicular means formation of follicles, which are aggregation of lymphoid cells. And what is the papillary reaction? It is epithelial hyperplasia. Coming to the treatment part, we learned that if it is bacterial, viral or chlamydial, we will always give antibiotics. In viral, we give for preventing the secondary infections. And if it is allergic, we go for anti-allergics and steroids. Now all of you give the heading membranous conjunctivitis. Membranous conjunctivitis, very simple, easy to learn. All the features that you know, all the 5 features, plus there is membrane formation, and this membrane is due to membranous way, it is a true membrane. That means when you will peel it, it will bleed. So that is what you have to write. All of you write down just like this. What is membranous? All the features, membrane formation which bleeds on peeling. All the features, membrane formation which bleeds on peeling. Okay. Exam question is, what is the cause? Cause you will answer is Corynebacterium diphtheria. Cause is Corynebacterium diphtheria. Second is, next condition, pseudomembranous conjunctivitis. Pseudomembranous conjunctivitis. Now the only difference here is this time this membrane will not bleed on peeling. So again write it down like this. All the feature, membrane formation, does not bleed on peeling. Does not bleed on peeling. This is your pseudomembranous conjunctivitis. Now coming again to exam question, make a cue, what are the causes? So causes can be, number 1, mild diphtheria, mild infections of diphtheria. Number 2, severe adenoviral infection, severe adenoviral infection. And number 3, it is Streptococcus hemolyticus, Streptococcus hemolyticus. So etiologies are important to learn in this chapter. Now give the heading angular conjunctivitis. As you all know, let's first understand, angular means the 2 angles of the eye, not of the chamber, anterior chamber, the 2 corners of the eye. This is the lateral canthus and medial. So only these 2 corners are involved along with excoriation of skin. This is called angular conjunctivitis. So angular conjunctivitis, write down, is conjunctivitis at the 2 canthi, conjunctivitis at the 2 canthi with excoriation of skin. With excoriation of skin. Okay, many people are finding my speed little faster, so I am repeating it and I am going to be slow. Let's see what I said. I said angular, first I am making you all understand. Stop writing and first understand. Angular conjunctivitis is when there is a conjunctivitis at the two angles, that is the two corners of the eye. Understood? And along with that there is involvement of the skin. Now let us write down. What is angular conjunctivitis? It is conjunctivitis at the two canthi with excoriation of skin. Conjunctivitis at the two canthi with excoriation of skin. Now what is asked in the exam is again, okay, I will just repeat the etiology first. Let us finish this one. What are the causes? Number 1, write down. We all know Moraxella Axenfeld. Moraxella Axenfeld. Second, write down Moraxella lacunata. This is another species, you should know the name, lacunata. And the third cause of angular is, Staph aureus. Third cause is Staph aureus. Treatment, these are all diplobacilli, Moraxella are diplobacilli. So it is all a bacterial infection, so how will you treat it? How we will treat this? Number 1, of course, antibiotic eye drops. Antibiotic eye drops. And along with antibiotic eye drops, for excoriation of skin, we give zinc oxide. This is again exam question. First cause was Moraxella Axenfeld, Axenfeld, Axenfeld. Okay? Okay, Shimla. Now, Bikaner, you had asked me to repeat the causes of pseudomembranous, so write down. Mild infections of diphtheria, severe adenoviral infections, and thirdly Streptococcus hemolyticus. Streptococcus hemolyticus. Now talking about one more thing I want to add in angular conjunctivitis, what is the role of zinc oxide lotion? What is this zinc oxide doing? So write down, it inhibits proteolytic enzymes. It inhibits proteolytic enzymes. So these were the two questions from angular. Next we talk about is, give the heading hemorrhagic conjunctivitis. Hemorrhagic conjunctivitis. Hemorrhagic conjunctivitis means conjunctivitis with subconjunctival hemorrhages. Whatever you all want me to repeat, please keep it on the end, we will repeat it. Don't disturb in between. I can't start repeating the whole lecture again after every 5 minutes. Okay, hemorrhagic conjunctivitis. This is conjunctivitis with subconjunctival hemorrhages. Conjunctivitis with subconjunctival hemorrhages. What are the causes? is again exam question. Causes can be bacterial, that is also asked in exam, or it can be viral, that is also asked in exam. Bacterial, let's learn the two causes are pneumococcus and Haemophilus. It is pneumococcus and Haemophilus. Talking about viral, you all know this, enterovirus 70. This is a very important exam question. Enterovirus 70. Second is Coxsackie 24. Third is Ecovirus 34 and fourth is Adenovirus. Suppose all the four are given in the options, that is I am repeating for you all. One was Enterovirus 70, Coxsackie 24, Ecovirus 34 and Adenovirus. If all four are given in the options, then we will mark the first one, that is Enterovirus 70. The most important is always Enterovirus 70. Now tell me, what are the causes of subconjunctival hemorrhages in the eye? What are the causes of answers, please? Let's talk also. What are the causes of subconjunctival hemorrhages in the eye? What all the causes you can think? One I have just told you is hemorrhagic conjunctivitis, isn't it? So causes of subconjunctival hemorrhage. Very good, Mysore. It is trauma. Very good. You are right, Mysore. Then no, Dhule, I don't think we mentioned alcohol as a cause of subconjunctival hemorrhage. Alcohol causes congestion. It doesn't cause hemorrhage. There is a difference between hemorrhage and congestion. Okay, you get red eyes, but you don't start getting hemorrhages there. Yeah. Yes, very good, Mysore. That's what I was asking. Very good answer. Hypertension. Very, very important cause. So now let's enumerate the causes. First, you don't forget to mention hemorrhagic conjunctivitis. Hemorrhagic conjunctivitis. Second is your trauma. Very good. Trauma is also a very good answer. Sometimes even foreign body can cause a little bit of hemorrhage if it's subconjunctivally, and very, very important cause, I am ticking it, is hypertension. It is hypertension. Yes. Very true. It is next very rightly answered. After hypertension, let's first answer this one, bleeding diastasis. Bleeding diastasis when the BT-CT is more. And finally, yes, Agro, it is pertussis. That is whooping cough. That is another cause of pertussis or whooping cough is another cause of subconjunctival hemorrhage. Pertussis or whooping cough. Good. So we now know what are the cause of subconjunctival hemorrhages. Now we talk about next is very, very important. Give the heading trachoma. On the heading itself, make 2 Qs. Everything is important. So trachoma is a chronic conjunctivitis of children or adults? Trachoma is a chronic conjunctivitis of children. Okay. It is a chronic conjunctivitis of children. Ludhiana, of which age group? 0 to 9. Okay. 0 to 9. So chronic conjunctivitis in children caused by what? Caused by Bhatinda, from wherever you have lost, please we are going to manage it later only. I cannot repeat the class. So please don't pursue again and again. Follow from wherever you are connected. Whatever problems we will take care later. Okay. Bhatinda, please. Okay. Coming to chronic conjunctivitis, this is, chlamydia trachomatis. Trachoma is caused by chlamydia trachomatis. They will not ask you this. What they will ask you is which strain. Chlamydia trachomatis, which strain? That is important. A, B, BA and C. A, B, BA and C. Okay. What does the strain D2K cause? What does the strain D2K cause? It causes adult infections, which is called adult inclusion conjunctivitis. That is called adult inclusion conjunctivitis. Yeah. So adult inclusion conjunctivitis is also called, exam question again, double Q. Please note down, it is also called swimming pool conjunctivitis. We also call it swimming pool conjunctivitis. Okay. So the D2K is mainly causing genital infections, and in the swimming pool it can lead to eye infections. So that is why we call it swimming pool conjunctivitis. Next we talk about, so these are the two questions, trachoma is caused by which strain and what is swimming pool. Now coming back to trachoma, which is a disease of children, I repeat, what are the clinical features? What are the clinical features of trachoma? The child will present with, let us make it easier, the child will present with IW. I teach like this so that it is easy for you. IW is itching and watering. Child presents with itching and watering. Itching, lot of watering. On examination, what you get? On examination, we will make a diagram as we always do. On examination, what you get is follicles on the upper palpebral conjunctiva and follicles on the upper limbus. Okay? Follicles on the upper palpebral conjunctiva and on the upper limbus. Now the one that is on the upper limbus are called Herbert follicles. Herbert follicles. Now pay attention. Trachoma is one infective cause of scarring of conjunctiva. Trachoma is the only infective cause of scarring. So what happens after the stage of inflammation where there is itching, watering and follicles, comes a stage of scarring, and when there is scarring on the upper palpebral conjunctiva, it is in form of a line. You all know this very well, double Q of your exam, this is called Art's line. We call it Art's line. And scarring on the upper limbus, on the Herbert follicles, this again double Q of your exam will lead to Herbert pits. It leads to Herbert pits. Okay. Next we talk about is, once we know this much on the clinical feature and on examination, we come to what is the WHO classification of trachoma. This is also asked in your exam. Many questions from this topic. WHO classification, and I think you all are very familiar with the mnemonic FIST O. So we classify into 5 stages and we learn it with the mnemonic FIST O. Okay. So what is stage 1? Stage 1 stands for follicles, but they will not ask you this, that is quite easy, F for follicles. What they will ask you is how many. So please learn with me, it is more than 5 follicles in upper palpebral conjunctiva. Upper palpebral conjunctiva, more than 5 follicles in the upper palpebral conjunctiva. So upper is also asked, upper or lower, you have to answer upper palpebral conjunctiva. Then I stands for inflammatory stage, inflammatory stage, that is itching and watering stage. Scarring means Art's line and Herbert's pit, so S stands for scarring stage, scarring stage. T is trichiasis, T is trichiasis. So what is trichiasis? What is trichiasis? Misdirection of eyelash. When due to scarring the eyelash turns in and it rubs on the cornea, we call it trichiasis. So trichiasis, and O stands for corneal opacity. O stands for corneal opacity. Okay? So this is the classification you are supposed to learn. Another very important question, let's make another Q and write down. What is the complication of trachoma? What is the complication of trachoma? Listen before writing, all of you. Whatever effects of scarring that you are learning, like trichiasis, entropion and so on, they are all considered the sequelae. Okay? So complication, that is only one. Always remember, complication is only one, and that is what? Corneal ulcer leading to corneal opacity. So complication of trachoma is only one. I repeat, corneal ulcer finally leading to corneal opacity. Next we talk about, after complication, give the heading pathology. If we learn under headings, we learn better. So let's do this way, we give the heading pathology. Now we learn two important points in pathology, and both are again exam questions. First is, this is one conjunctivitis where there is both follicular and papillary reaction. Both follicular and papillary reaction. So this is one conjunctivitis where you get both the pathological reactions. Second, they ask you on HP bodies. You must have learnt in your MBBS already that HP bodies, they are intracytoplasmic inclusion bodies. Intracytoplasmic inclusion bodies. What does HP stand for? Let's learn it. HP, if suppose they give in the options, you should know, it is Halberstedter Provesac. Okay, Halberstedter Provesac. Now give the heading community ophthalmology. I am still talking about trachoma, community ophthalmology. First point to remember, which is asked every year, make 2 Qs and learn what is SAFE strategy. Many of you must be knowing SAFE strategy. You are a regular batch, you know what is SAFE strategy. Now SAFE strategy, S stands for surgery, A is antibiotics, facial hygiene and environmental cleanliness. So what is SAFE strategy? It's a WHO program to control trachoma in a community. It's a WHO program to control trachoma in a community, where S stands for surgery, A is antibiotics, facial hygiene and environmental cleanliness. Facial hygiene and environmental cleanliness. This is not enough. What next they ask you is, which surgery is included under this program? So please remember the next question, the only surgery is trichiasis surgery. Trichiasis surgery. Which antibiotics? In SAFE strategy, both are included. Either we go for topical tetracycline or we go for oral azithromycin. Okay. Now suppose in your question both are given in the option, then we should always mark azithro because it is easier to give with better compliance compared to tetracycline, which is always available only in ointment form, and it is cumbersome to put ointment in the eye, and therefore the compliance is not so good. Next question again, what is asked in SAFE is, what is the percentage of tetracycline? This was last year NB style question. You will answer 1% tetracycline. It is 1% tetracycline eye ointment. So please remember this 1%. Then they have also asked you the dose of azithromycin used in SAFE strategy for trachoma. So it is 1 gram for adults, 1 gram for adults and 20 milligrams per kg for children. So for children it is 20 milligrams per kg. Okay, next we talk about is, still not enough. Another question from SAFE is, what is the criteria of starting a safe strategy in any area? How do I know that in this area I should start the safe strategy? So for that, this was your last year question. So for that, we take the prevalence of trachoma follicles. Okay, we take the prevalence of trachoma follicles. If this prevalence of trachoma follicles is more than 10%, we will follow the safe strategy. But if it is between 5 to 10%, then better go for only F and E, that is facial hygiene, environmental cleanliness. And if it is less than 5%, then nothing is done. Less than 5%, nothing is done. We don't start the safe at all, less than 5%. Okay? So that was so many questions from safe strategy. What is the next thing that you're supposed to know? The next thing, number 2 point under community ophthalmology, is that trachoma is included in Vision 2020. Okay, you all know what is Vision 2020? Again, it is a WHO program to control trachoma to control 5 diseases by 2020, isn't it? WHO program which includes 5 diseases to be controlled totally by 2020. We'll come to Vision 2020 later. First of all, let's understand this, that trachoma is one of the diseases in this program. Let's finish trachoma before I come to Vision 2020. The third thing is, they ask you, what is the drug of choice for blanket therapy in trachoma? Now, what is blanket therapy? Blanket therapy means mass therapy for prevention. That is important. It's a mass therapy for prevention. So, in blanket therapy for trachoma, again you give azithromycin. You will answer the drug of choice is azithromycin. Okay? And of course, the dosing is the same, azithromycin. Second important question is, what is the criteria of starting a blanket therapy in any area? It is given that again we take the prevalence of trachoma follicles of more than 5%. You can start with your blanket therapy. Good. So that was about the community of ophthalmology. Now give the heading, treatment of trachoma. What is the treatment of trachoma? Again exam question, what is the drug of choice? Since last year we were answering the drug of choice as tetracycline, but now after too much of research we have come to the conclusion that we should answer it as azithromycin. So let's answer the drug of choice for treating trachoma as azithromycin, because again of the same reason that it is easy to give, more compliant, more effective. And what are the other antibiotics you can give? You can write down, you can go for sulfacetamide eye drops, or you can go for any broad spectrum antibiotic. We can go for any broad spectrum antibiotics. Right? Next we talk about, so that was about trachoma. Okay, now we talk about Vision 2020. Before I move further, we shouldn't miss this. What are the diseases in Vision 2020? Again, this is asked in the exam. First is cataract, then trachoma, onchocerciasis, childhood blindness and refractive errors. Childhood blindness and refractive errors. Okay, please note down and you should learn all these 5 diseases by heart. Cataract, trachoma, onchocerciasis, childhood blindness, refractive errors. Now tell me the next question they ask you, what are the diseases of Vision 2020 for India? Now for India, we will cut onchocerciasis. Onchocerciasis is not a disease in India. And what are the two among, now we are left with 4 diseases, we will add 3 more on, that is total 7. What are the 3 more we add? Diabetic retinopathy, then glaucoma and corneal blindness. Corneal blindness. Diabetic retinopathy, glaucoma and corneal blindness. Right? Good. Now give the heading. What is the next topic we will learn is allergic conjunctivitis, and the first allergy we will learn here is flexular keratoconjunctivitis. Flexular, it is keratoconjunctivitis, that means cornea is also involved. Keratoconjunctivitis. First exam question, this is allergy towards endogenous antigen. It is allergy towards endogenous antigen. Now they will ask you which endogenous antigen. So first answer and preference is always to Staph aureus. So Staph aureus, and second is tuberculosis. Talking about clinical features, how will the patient of flexular present? Very simple again, IW. Any allergy presents with itching and watering, we all know that. So IW, itching and watering. On examination, again let's make a diagram. What we see is a flectin. Flectin is nothing but a nodule, okay. So flectin at the limbus, this is the first finding. Along with that, there will be conjunctival congestion. And because it is a keratoconjunctivitis, corneal involvement will lead to, sorry, it should be something like this, yeah, I will make it here again. Corneal involvement will lead to fascicular ulcer. Fascicular ulcer. Okay, okay Aldwani, please note down what I said. Flexular keratoconjunctivitis is an allergy towards endogenous antigen. Okay, endogenous antigen, and which endogenous, if they ask you, first is always, you will answer Staph aureus and then tuberculosis. Clinical features, patient will present with itching and watering. Let's make a better figure here. Itching and watering. On examination, what we get is, making again, on examination what you get is a flectin at the non-limbus. Flectin is a nodule. And later, and along with that, what I can get is conjunctival congestion. When cornea is involved, that will lead to formation of fascicular ulcer. Fascicular ulcer will later extend. Now pay attention, I am not repeating but moving further. So all of you pay attention. This fascicular ulcer later extends as ring ulcer. This is called ring ulcer. Okay, so that is it. Now we talk about treatment of flexular. Now if you talk about the treatment, of course you know it's an allergic conjunctivitis, so you give anti-allergics, and the new group of drug that we are now giving these days, it has both the actions. It is a mast cell stabilizer also and antihistaminic also. Let's learn the names of these drugs that we are nowadays giving as a first line treatment. Both the actions are there. Name of these drugs, which are all mast cell stabilizer, I am repeating, they are mast cell stabilizers and antihistaminic. These are number 1 olopatadine and epinastine. Olopatadine, epinastine. Okay. Second, we can also go for purely mast cell stabilizers, and that is what? Sodium chromoglycate. That is sodium chromoglycate. And of course, if nothing works, what will work is steroids. We want to avoid steroids because I taught you earlier, because it can cause glaucoma, it can cause cataract. So we give a milder steroid like fluoromethalone we prefer, so steroids. This is the treatment of flectanular keratoconjunctivitis. Let us come to the next allergic conjunctivitis. Next is vernal keratoconjunctivitis. Vernal keratoconjunctivitis. It is also called spring catarrh, also called spring catarrh. Catarrh means watering from nose and eyes, that is called catarrh. So, does it happen in spring? No, it is a disease of not of spring but of summer. So, it is a misnomer. Just like you have learned that retinoscopy is a misnomer, this is also a misnomer. It does not happen in spring. Okay, then we talk about what are the clinical features. First important point, this is allergy towards exogenous antigen. Allergy towards exogenous antigen like dust and pollen. Okay. Number 2, this is a disease of summers. It is a disease of summers. Which group of people are involved? They are generally male children. Male children. Very important point after this, make a nice cue and write, there is only papillary reaction, so no follicular reaction. Remember in trachoma it was both, in vernal keratoconjunctivitis no follicular reaction, only papillary reaction. Clinical features, the child will present with, again you all know, IW, itching, watering, and again an exam question, ropey discharge. It presents with ropey discharge. Ropey discharge means there are fibrin threads in the discharge. That is called ropey discharge. Coming to on examination, again let us make a diagram here. So, what you will get here is papillary hyperplasia on the upper palpebral conjunctiva. So, these are raised polygonal areas on the upper palpebral conjunctiva and papillary hyperplasia on the upper limbus. Okay. Now, this when severe, we all already know is exam question, and what do you call it? Cobblestone appearance. This is cobblestone appearance. Make a double Q there, all of you. It is a cobblestone appearance. And papillary hyperplasia on the upper limbus, they have got central dots. These are eosinophils, and these are called, again exam question, Horner-Trantas spots. Horner-Trantas spots. And it is again a keratoconjunctivitis. Therefore, corneal involvement is in form of a white opacity on the cornea, and this is not green, okay, it is white opacity. What do you call it? Cupid's bow. We call it Cupid's bow. The other name of Cupid's bow is pseudogerontoxin. Now what is gerontoxin and why do you call it pseudogerontoxin? So gerontoxin actually is another name of Arcus senilis. Gerontoxin is another name of Arcus senilis. So because when it develops as a white opaque state, it resembles Arcus senilis. Okay, we have learnt Arcus senilis in the cornea chapter. So it resembles Arcus in the initial stage. When Arcus senilis starts forming, it is not in one go that it will become a circle. It will first form on the upper and lower part, and then it will form as a circle. So initial stage of Arcus resembles this, so we call it pseudogerontoxin. Another exam question, a lot of questions from this topic. Another exam question is Maxwell-Lorentz sign. What is Maxwell-Lorentz sign? Please note down, this is eosinophils, presence of eosinophils in the ropey discharge. Eosinophil, not ropey discharge. Maxwell-Lorentz is not ropey discharge. Many of you answer that, but the guides are wrong. Maxwell-Lorentz is eosinophils in the ropey discharge. That is called Maxwell-Lorentz sign. Okay, and what next then? After this, another exam question is, what is the type of hypersensitivity reaction? Now think yourself, what will be the type of hypersensitivity reaction? It's an eosinophils, so it is type 1 hypersensitivity. This is also exam question, that vernal keratoconjunctivitis is a type 1 hypersensitivity reaction. Type 1 hypersensitivity reaction. Yes, very good. So that was it. Now we talk about treatment. So many exam, this is also exam question, make a cue here also all of you. Treatment is again same as flectanular. Whatever we discussed in flectanular, it is also an allergy and we give the same treatment. Now give the heading Ophthalmia neonatorum. Ophthalmia neonatorum. It is also called neonatal conjunctivitis. Also called neonatal conjunctivitis. Defined as any conjunctivitis within 1 month of age. Any conjunctivitis within 1 month of age. Okay. Now what are the causes of neonatal? Write down all of you. First is chlamydia. Chlamydia. Second is gonorrhea. Let's learn the whole list. First is chlamydia, then gonorrhea, then chemical conjunctivitis. What next after chemical? Staph aureus, and finally write down herpes simplex. So these are the causes of neonatal conjunctivitis: chlamydia, gonorrhea, chemical conjunctivitis, Staph aureus, herpes simplex. Exam question: which is the most common cause? You will answer chlamydia. Most common cause, chlamydia. Okay? Okay. Next important question is, what is Creed's method? So you all know what is Creed's method? Padha tha? Creed's method. Let me explain first, then we will write. See, if a child is born from a mother who is infected with gonorrhea, this child has a very high risk of developing gonorrheal conjunctivitis, and that can be blinding also. It's a very dangerous condition. So in these children, just immediately after birth, to prevent gonorrheal conjunctivitis, we give 1% silver nitrate. To prevent gonorrheal, we give 1% silver nitrate in both the eyes, and this method of preventing is called Creed's method. This is called Creed's method. Second important thing, this is not applied now. Both the things can be asked. What is Creed's method? Whether we do it now or not. We don't do it now. We don't follow this. Another important thing is that if you are giving a silver nitrate in the child's eye, any chemical in the child's eye will lead to chemical conjunctivitis. So what is chemical conjunctivitis? Nothing but conjunctivitis due to silver nitrate. It is nothing but conjunctivitis due to silver nitrate. That is chemical conjunctivitis. Okay. Coming back to after this, there is another question from the neonatal, and that is how fast you will get each. So immediately in a day or two, what will you get first is, within 24 hours you can get is chemical. Within 24 hours you can get chemical. Then you can say up to 2 to 3 days is gonorrhea, and above that is chlamydia. Okay. So within 24 hours you can get chemical conjunctivitis, you will get earliest in a day. 2 to 3 days for gonorrhea to manifest, and around 3 to 5 days for chlamydia to manifest. 2 to 3 days for gonorrhea and around 3 to 5 days for chlamydia. So these are the questions from ophthalmia neonatorum. Now give the heading vitamin A deficiency. Vitamin A deficiency. We also call it xerophthalmia. We also call it xerophthalmia. Okay, this vitamin A deficiency or xerophthalmia, before I go further into what are the features, of course that is asked in the exam, let's learn this way that xerosis of the conjunctiva is of two types. Xerosis दो तरह की होती है. What is xerosis? Xerosis means drying. So drying can be either epithelial xerosis in the conjunctiva, or it could be a parenchymatous xerosis. So xerosis can either be epithelial or it can be parenchymatous. Epithelial xerosis is the one which will occur due to vitamin A deficiency, and parenchymatous, that is nothing but all the causes of scarring of conjunctiva. Scarring of conjunctiva. So what are the causes of scarring of conjunctiva? Let's learn it. One we have just learned is trachoma. Scarring of conjunctiva, first is trachoma. Second, write down all types of burns, chemical, thermal, radiational, electrical, all types of burns. Stevens-Johnson syndrome. Stevens-Johnson syndrome. Okay, so these are the causes of scarring. Now there is another question here, which is more dangerous, acid or alkali? It is always alkali. Which is more dangerous? So it is alkali is always more dangerous. Why? Because it can penetrate the cornea and go inside. So it damages the inside structures of the eye as well. Okay. Therefore, alkali burn is always more dangerous than acid burn. Now to talking about the features of vitamin A deficiency, we will learn by WHO grading. Again it is asked in the exam, you are supposed to know the WHO grading. So WHO grading says any xerophthalmia can be axon. You all know that vitamin A is an important component of rods. So when there is a deficiency, first thing that is affected is rods. So axon, that is night blindness. What is night blindness called? nyctalopia. We call it nyctalopia. Then comes X1, which you further divide as A and B. X1A is conjunctival xerosis, and when this xerosis becomes too much, B is Bitort's spot. Bitort's spot. You all know this. Then comes X2, that is corneal xerosis. Now there is a corneal drying or corneal xerosis, that is X2. Then 3 again further divide into A and B. A is melting of the cornea called keratomalacia, but that is involving less than 1/3 of cornea, and B is keratomalacia involving more than 1/3 of cornea. XS is xerophthalmic scarring, and F stands for xerophthalmic fundus. So this is the grading of xerophthalmia. Now have you all thought about what do you mean by xerophthalmic fundus? How does that look like? So xerophthalmic fundus is a white spotted fundus due to changes in the outer segment of rods. I am repeating, it is a white spotted fundus due to the changes in the outer segment of the rods. So this grading is asked in your exam. They can ask you what is grade 2, what is grade 3. The question that had previously come was what is grade 3B. So please remember the grading very nicely so that you can answer well. Another question, NB style, asked last year only I suppose, Bitot spot is more common where? Temporally or nasally? Again my research says that Bitot spot you will answer first of all outer surface of what? Outer segment of the rods. I said Bilaspur, outer segment of rods. We are talking about fundus changes. So that is due to changes in the rods because of vitamin A deficiency. It is the outer segment of rods. That is what I said. Coming back to, you will answer Bitot spot is commonly on both the sides, nasal and temporal, but if I have to choose one, next option I will choose is temporal. Okay. Either both is given, then you answer both, otherwise temporal. Yes. Another question that is further you should be answering about is treatment of vitamin A deficiency, that is again a Q, will depend upon okay, don't panic. Coming back to, now you all can hear me. Coming back to treatment part, coming to treatment of vitamin A deficiency. Treatment of vitamin A deficiency will depend upon the age of the child. If our patient is more than 1 year, okay, learn it with me here itself, more than 1 year, right? Then injectable I am talking about, vitamin A is given 1 lakh international unit on, this is very important, 0, 1 and 14th day. I hope you all know what it means. Today I will give one injection, tomorrow another, and after 2 weeks. So total of 3 injections. Now learn with me that if our patient is less than 1 year of age, I just halve the dose. I halve the dose. And if it is oral, if I am trying to give oral instead of injectable, in each case just double the dose. Isn't it? Oral is always given double of injectable. So you will just double the dose. Okay? So this is how we learn the treatment of vitamin A, which is again asked in the exam. Treatment of vitamin A deficiency, I meant to say. Coming back to another very important thing before I move further, what are the causes of night blindness? So what are the causes of nyctalopia? Okay, let's learn it. Number 1 ho gaya xerophthalmia that we just mentioned. Xerophthalmia. Second is retinitis pigmentosa. Retinitis pigmentosa. Number 3, write down high myopia. High myopia. And what is high myopia? Myopia of more than 6, I taught you. So high myopia. And finally, late stage of primary open angle glaucoma. Late stage of primary open angle glaucoma. Anything else? Yes, now we are supposed to learn even more than this list because that's been asked in the exam. So next is Oguchi's disease. Oguchi's disease. So what is Oguchi's disease? Learn with me. It is night blindness with pale fundus. Fundus is not red, it is yellowish in color, that is pale fundus. This is Oguchi's disease. Night blindness with pale fundus. Now there was a question here last year on Oguchi's disease from AIMS, and what they had asked, make a Q and learn. What is Meso's phenomenon? What is Meso's phenomenon? So all of you, let's first listen before I write. See, when this patient who is suffering from night blindness, who is suffering from Oguchi's disease, is asked to stay in dark for 1 hour. He is made to sit in the dark for 1 hour. After an hour, he starts seeing in the dark. His night blindness is gone. And when I examine his fundus, the fundus is not pale, now it is red and normal. So this reversal of symptoms, now write down, reversal of symptoms, or you write like this, sitting in the dark for 1 hour, no night blindness, fundus is normal. Sitting, I'll explain you why. Sitting in the dark for 1 hour, no night blindness and fundus is normal. So this is what is Meso's phenomenon. Now why it is happening is actually in these patients the number of rods are quite less compared to the normal. So what will happen that once you have asked the patient to sit in dark for 1 hour, now what will happen, the remaining rods, they get activated and therefore the symptoms are reversed. And similarly, why is the fundus pale? Because the visual purple of the rhodopsin has turned into visual yellow. So when the patient again sits in the dark for a long time, it again comes back to visual purple. So this is the reason. Nobody will ask you so much in detail, just for your understanding. But Meso's phenomenon you should know is related to Oguchi's disease. What is the next cause after the Oguchi's? Write down for night blindness is fundus albi punctatus. Fundus albi punctatus. So fundus means retina, albi means white, punctatus means dots. So what you see here is white dots on the retina. This is fundus albi punctatus. These are the white dots on the retina, white dotted fundus, along with night blindness. This is fundus albi punctatus. Next cause, okay, so it is white spotted fundus along with night blindness. Next cause is choroideremia. Next cause is choroideremia. So choroideremia क्या होता है? What is choroideremia? This is dystrophy of choroid. I already taught you what is dystrophy when I was teaching you cornea. So any spontaneous idiopathic change. So this is dystrophy of choroid. And lastly, write down gyrate atrophy. Gyrate atrophy. So what is gyrate atrophy? Again pay attention. What is gyrate atrophy? It is again a dystrophy of choroid. It occurs due to deficiency of, this was your exam question. It occurs due to deficiency of ornithine aminotransferase. This is what Kansky says, but the other enzyme could be ornithine transcarbamylase. So whatever, the main thing is there is a disturbance in the urea cycle. What was the question asked? Is how to treat gyrate atrophy? Treatment consists of arginine free diet. You all know arginine is a precursor of ornithine. So arginine free diet. And 50% of the patients can also respond to vitamin B6 therapy. Both were given in the options. You would mark arginine free diet. Okay, so arginine free diet and vitamin B6. So these are the causes of night blindness and the questions that are asked. Come to what are the causes of day blindness or hemerlopia. Day blindness, what do you call it? Hemerlopia. What are the causes of day blindness? Think yourself. In the daytime, pupil is constricted. So naturally, any opacity at the center of the cornea or at the lens will cause day blindness because the pupil is narrow. So you will write like this: central corneal opacity, central lenticular opacity, central lenticular opacity, and you all know cones are responsible for day vision. So congenital absence of cones. Congenital absence of cones. Okay, good. So that was about vitamin A deficiency, what is nyctalopia, what is hemerlopia, and what are the causes. Now let's come to talking about, next is dry eye. Give the heading, dry eye. Dry eye. So what are the layers of the tear film? What are the layers of the tear film? Lowermost layer is the mucin layer. Okay. Lowermost is the mucin layer. Then comes the aqueous layer. And finally the lipid layer. So I repeat, there are three layers in the tear film: mucin layer, aqueous layer, lipid layer. Now mucin is secreted by, as in the exam, mucin is secreted by goblet cells of the conjunctiva. Mucin is secreted from the goblet cells of conjunctiva. And you all know what is mucin doing? It is helping to spread the tear on the ocular surface. It helps to spread the tear on the ocular surface. What is next? Aqueous layer. Write down aqueous is secreted by lacrimal and accessory lacrimal glands. lacrimal and accessory lacrimal glands. And the role of aqueous layer is lubrication. Aqueous layer is lubrication. Coming to the lipid layer. Lipid layer is secreted from meibomian glands. Meibomian glands. Okay. And again, what is the role of lipid layer? It prevents evaporation of the tear. Prevents evaporation of the tear. There is another question I missed. Let us pay attention to that question. And the question is, density of goblet cells is maximum at. So, density of the goblet cell is maximum at, you will answer, nasal conjunctiva. Density of the goblet cell is maximum at nasal conjunctiva. Okay, just now I am seeing there is some confusion regarding. Okay, many of you have got a confusion about what is Mesos phenomenon. So, let me explain it to you once again. Yes, I can see that. Repeat the fifth and the sixth cause. Okay. Let me repeat the causes of nyctalopia. I think many of you have got the doubts on that. Okay. I will repeat the cause of nyctalopia before moving further. Just now only I had a look at it. So, coming back to nyctalopia, first I will deal with that. First cause was xerophthalmia. Second, retinitis pigmentosa. What was third? High myopia. High myopia. Fourth is late stage of primary open angle glaucoma. Okay. Yeah, Ludhiana, you have asked me whether the peripheral cataract could be a cause. You can mention it as a cause. Okay, you can mention it as a cause. That's not a problem. Okay. Mesos phenomenon, please explain. Okay, Rohtak. So that's what I'm trying to do. I'm trying to repeat all the causes and then I'll repeat the problems. Yes, I'm reading. Allahabad also had the problem to repeat the fifth and the sixth. Okay, I'm just repeating everything. So after that, coming back to what I said was, after late stage of primary open angle, my next cause was Oguchi's disease. I told you that Oguchi's disease is night blindness with pale fundus. Oguchi's disease is night blindness with pale fundus. I explained you that fundus is pale because the visual purple has become visual yellow. You will have to revise your rods and cones, rhodopsin, and then only you will be able to understand what was visual purple and yellow. So coming back to Oguchi's disease is pale fundus with night blindness. Now I said, what is Mesos phenomenon? I said, when this patient of Oguchi's disease, I hope it should be better now, Vikane. When the patient of Oguchi's disease is sitting in dark for 1 hour, then this patient's night blindness is cured. He starts seeing in the dark and the fundus is also not pale. When I do the fundoscopy, the fundus is normal. Just remember, reversal of the findings, this is what is called Mesos phenomenon. It is a feature of Oguchi's disease. Coming to next cause is fundus albi punctatus. Fundus means retina albi means white, punctatus mean dot. So this is night blindness with white spotted fundus. Night blindness with white spotted fundus. And the last two causes I said was choroideremia, which is again a dystrophy of choroid, and another dystrophy of choroid is gyrate atrophy. These are two are also causes of night blindness. Okay. Now then I talked about that gyrate atrophy is due to a deficiency of enzyme ornithine aminotransferase. Deficiency of enzyme ornithine aminotransferase. Bhatinda, what have you written in short? Can you please write it properly? Put a caps lock and then write. I can't get it in short what you have written. Okay, then coming to clear. Okay, very good. Then what is the treatment of gyrate that I was trying to explain is all the patients are responding to arginine free diet. Agatala, I think now your speed is okay. I am very slow. Arginine free diet. Yeah, Allahabad, you are clear with your 5th and 6th cause, I hope so. And second is vitamin B6 as a, that is pyridoxine. Now, but vitamin B6 only 50% of the patients respond. In your question, both were mentioned as options. In that case, we will answer arginine free diet. Okay, in that case, we will answer arginine free diet. I hope you all have written the causes of day blindness. Let's come back to dry eye where I taught you the layers of the tear film. So let me repeat it again for you all. I said the layers of the tear film. Lowermost is the mucin layer. I am really sorry, but if you find me this also fast, I can't help it. I am already singing, I am not teaching. Huh? So what I said is that the tear film has 3 layers. Let us, yeah Shimla, I think I should continue. The tear film has 3 layers. All of you who have any other doubt, note it on the paper. We will talk at the end of the session. Okay, so mucin layer I said is formed from the goblet cells of conjunctiva and helps in spreading the tear film. Aqueous layer, this is from lacrimal and accessory lacrimal glands, lacrimal and accessory lacrimal glands, and the role is lubrication. So this is your aqueous layer. Coming to the lipid layer, this is formed from meibomian glands, meibomian glands are found on the lids, right? Meibomian glands. Okay. Agroha, you are from the foundation batch, you are not able to follow. To be very, let me be very clear to this time, what I am sitting with is only with the regular batch. Foundation batch is not supposed to be sitting in this class. Please clear it again from the head office, okay? I am taking class of regular batch, maybe that's the reason you all are finding me very fast or so, but I don't think I am fast. I teach foundation also in the same speed, okay? I have been told this is all regular batch. No mixing this today. Okay, coming to meibomian glands are found on the lids. Let's concentrate on the studies. Please don't disturb me. Talking about, I'm not going to see now anything what you all are disturbing too much. Come on, now let's study. Whatever batch you are, please sit and study. Coming to meibomian glands. This helps to prevent this secretes lipid and it helps to prevent the evaporation of the tear film. Okay, now we talk about another exam question. Where is the density of the goblet cells maximum? I told you it is nasal conjunctiva. Density of goblet cells is maximum at the nasal conjunctiva. Density of goblet cell maximum at the nasal conjunctiva. What is dry eye? Dry eye is deficiency of any of the three layers, whether it is mucin or aqueous or lipid. Deficiency of any of the three layers is called dry eye. Deficiency of any of the three layers is called dry eye. Okay? Then what is keratoconjunctivitis? Sorry, keratoconjunctivitis. In short, we write it as KCS. Anyone? Question is now open to all. What is keratoconjunctivitis? It is deficiency of which layer of the tear film? My question is this. So, keratoconjunctivitis. Sjogren syndrome is not keratoconjunctivitis, right? Keratoconjunctivitis is deficiency of, yes, Shimla, it is aqueous layer. So this is very important. Pay attention, all of you. There was an exam question and the question said mucin layer deficiency is seen in, and all your seniors, you all have answered KCS. KCS is not a deficiency of mucin layer. KCS is deficiency of only aqueous layer of tear film. Please remember that. And now, as you all rightly said, if KCS is associated with xerostomia, that means dry eye is associated with dry mouth, xerostomia. Now you will call it Sjogren syndrome. And this is our primary Sjogren syndrome. This is primary Sjogren syndrome. And this primary Sjogren syndrome, when it is associated with connective tissue disorders like rheumatoid arthritis, okay, or any other connective tissue disorders, now we call it secondary Sjogren's. Now it becomes secondary Sjogren syndrome. When associated with any connective tissue disorders, we call it secondary Sjogren syndrome. Right? Next we talk about what are the clinical features of dry eye. Write down, how will a patient of dry eye present? Number 1, burning sensation. Second is your gritty sensation. Gritty sensation. Gritty means foreign body sensation. Something is pricking in the eyes, that is called gritty sensation. What next? If it is very severe, it can even lead to diminution of vision. I taught you what is diminution of vision. Any vision of less than 6/6. So it can lead to diminution of vision. Investigation. How do you investigate a dry eye? First is slit lamp examination. On slit lamp examination, what I am trying to see is the height of tear meniscus on the lower lid. So what is this height of tear on the lower lid? It should be 1 millimeter. It should be 1 millimeter. Okay. Second is, what is this? Was one slit lamp examination was first. What is the second investigation that you can go for is Schirmer's test. Everybody has learned this. Schirmer's test. So what is Sherman's test? You put a strip of paper on the lower lid. Everybody has learned this. That strip of paper has markings. Therefore, what do you call that? You call it tear strip. You're putting it on the lower lid for 5 minutes, and what you're measuring is the amount of wetting of the strip. So, if the amount of wetting is less than 5 millimeter, when keeping for 5 minutes the wetting is less than 5 millimeters, then this is dry eye. So Sherman's test is when the wetting of the tear strip is less than 5 millimeters. Less than 5 millimeters. Next is tear film breakup time. Tear film breakup time. Now what is this is? What is the number of seconds it takes for the continuity of the tear film to be broken? So how do you see that is, you ask the patient, just listen, ask the patient to blink once and then keep staring. He is only blinking once and then he is keeping his lids still. You have put on the stopwatch as soon as he did his last blink, right? Now what are the number of seconds? The first dry spot appears on the cornea. That means the continuity is broken. If these number of seconds is less than 10 seconds, it is dry eye. So I again repeat for you all, you can write down number of seconds from the last blink to the dry spot from the, okay, write like this. Number of seconds it takes for the first dry spot to appear okay. Ludhiana, I'll just answer you. After the last blink, So this is what is BUT. Now less than 10 seconds again is dry eye. Ludhiana, we are all talking about basal. What do you mean by reflex tear production? What is a reflex tear? This is not a dictation, Agadara. Please don't expect to write everything. I just told you, read it yourself. What is BUT? If you have any problem, you can ask me in the next class. So anything less than 10 seconds is dry eye. I have said, Ludhiana, when we say reflex production is when you are emotionally disturbed or there is any pathology in the eye, there is some foreign body in the eye, that is what is reflex tear production. We are mainly talking about the basal production, that is why you are getting these problems of grittiness and burning sensation. That is what is affected. Okay. So actually, if you are sad, you cry, that is also reflex. If there is any foreign body on your eye, that is also, we are not talking about reflex, this is all basal production. When people working on the computer, why do they have the dry eye? Because they keep on staring on the screen. Blinking is less, so the evaporation is more, and therefore you start getting dry eye. Okay? Yeah. Good, Ludhiana. Next, come to the next question, next investigation after BUT is rose Bengal staining. Rose Bengal staining. Tell me, what was the stain we used in the ulcer? It was fluorescein stain. Now here I am using what? Rose Bengal stain. So let's learn what does it stain. Rose Bengal stains dead cells and mucus. Rose Bengal stains dead cells and mucus. Got it? Now how will a rose Bengal staining look like? Let us see in this figure itself. Think yourself. All this part of the eye is dry. It is a dried conjunctiva. So you will see it, everything is stained like this, and we typically describe it as two triangles base at the limbus. Okay, two triangles. So this is the rose Bengal staining. Rose Bengal staining is two triangles base at the limbus. What is the next investigation after rose Bengal is tear osmolality measurements, and tear osmolality is increased in patients of dry eye. Again, tear osmolality naturally is going to be more in patients of dry eye. Okay? Now we come to the treatment part. How do you treat a dry eye? Divide it into two, medical and surgical. Medical, we all know we give lubricating eye drops. Lubricating eye drops, most commonly used exam question, make a Q and write, you all know it, I know, is methyl cellulose derivatives. Methyl cellulose derivatives. But what are the other lubricating eye drops? Derivatives of hyaluronic acid, that is hyaluronates. Even they can be used as lubricating eye drops. Or earlier we used to use, okay, I will again repeat because I think I was a little fast. First is methyl cellulose derivatives. It is the most commonly used now, so make a Q. If they ask you most commonly used, you will answer methyl cellulose derivatives. Second, I said hyaluronates. This is a second type of tear substitute. And third type is combination of polyvinyl alcohol with povidone. Polyvinyl alcohol with povidone. So these are the three types of lubricating eye drops. Now we talk about, answer me this one, all of you. It's an open question. What is the surgical treatment of dry eye? What is the surgical treatment of dry eye? I am waiting. No one can answer this one. Surgical treatment of dry eye? No, my sir, we don't do tarsography. No, Allahabad, not tarsography. Why not? Very good, Ambala, you got it. It is lacrimal punctal occlusion. Okay, you occlude the puncta, lacrimal punctal occlusion. So you don't do tarsographies. What we go for is we occlude the puncta so that the tear is staying for a longer time. There are small silicone plugs are available, just plug it. This is lacrimal punctal occlusion. Yes, very good, Mysore. Now we talk about pterygium. That is another very important topic from conjunctiva. Asked in your exam. So let's learn something about pterygium. Give the heading pterygium. Write down. It is a subconjunctival fibrovascular tissue encroaching the cornea. Make the figure, all of you. I am repeating it. It is a subconjunctival fibrovascular tissue encroaching the cornea. Clinical features. What it is causing is very important, cosmetic problem. Most commonly it is cosmetic problem. Number 2, it can alter the corneal curvature causing astigmatism. It can alter the corneal curvature causing astigmatism. Number 3, look at the diagram. If it grows so much that it is encroaching the pupillary area, then as you see there can be diminution of vision. If a person is not aware of it and he is very careless enough not to get excised in time, this will grow over the pupillary area leading to diminution of vision. Okay, so why does it occur? Now we learn what is the etiology. It is mainly due to ultraviolet ray exposure. Pay attention, again exam question, which ultraviolet ray? It is always B. UVB is dangerous for the eyes. It is UVB. Okay. Next thing is Very important NB style exam question. Pterygium is more common where? So it is more common nasally. And why it is more common nasally? Let's understand. All of you look at me and let's understand what I am saying. The ultraviolet rays, the lateral rays, they focus very nicely on the nasal half of the conjunctiva. But take my right eye. The lateral rays are focusing very nicely here. But what about from the other side? From the other side, it is interrupted by the nose. So because of the nasal bridge, the focusing on the temporal half is not proper, and therefore it is always more commonly nasally. Why I explained you the reason is, you ever get confused where what is the answer, you will remember the reason and you will answer correct. So pterygium is always more common nasally because the focusing of the ultraviolet rays, lateral rays are focused better on the nasal half, whereas on the temporal half they are interrupted by the nose. Okay. Next we talk about treatment of pterygium. You all know is excision. We treat it by excision, but what is the main concern here is recurrence. So how to prevent recurrence? Again exam question. How to prevent recurrence? There are two methods. Prevention of recurrence, there are two methods. One is mitomycin C and second is autografting. Second is autografting. Okay, one is mitomycin C and second is autografting. Exam question, which one is the better modality? Are you listening? Which one is the better modality? Please you will answer autografting. Make a nice cue there. Autografting. Let's understand a little bit about autografting. From the same eye, you are cutting a block of conjunctiva and putting it. That's what it means. Just look at the figure, all of you. Nothing much to write, just understand. Suppose this was the pterygium here. Okay, I have removed the pterygium and this is the Breyer's sclera. Now what I do, suppose it is nasally, this pterygium is nasal. So from the superior temporal quadrant, I will cut a block of conjunctiva here. I dissect little further so that limbal stem cells are included in my graft. That is important. Now this is the X side of the graft which is towards the limbus, and this one is the Y side. What is important and what I have to be careful enough is that when I am putting this graft here, the X side should come again on the limbal side and this should be the Y side. So that, what is the purpose? The limbus stem cells are transferred from here to here. Okay, that will help in healing the cornea which has been encroached by pterygium. So this is what is called autografting. And some of the students ask, what about this one? What about this one? MMC Jabalpur is mitomycin C. It is mitomycin C. And what about this one? When we have cut the conjunctiva, we don't need to even stitch it. It will regenerate by its own. It's not such a big block that you keep stitching it. We don't even stitch it. We leave it like this only. So this is autografting. Jabalpur MMC is mitomycin C. In short, we write it as MMC, mitomycin C. Right? Okay, so that was about pterygium. Now let's see how the tear is drained. We have talked about how it is formed and how it is drained. Okay. Turn the page, all of you, and give the heading. Turn the page and give the heading lacrimal drainage system. Give the heading lacrimal drainage system. Make the diagram. Let's see how the tear is drained. These are the two puncta. Okay. Then these are the two canaliculi which go into the common canaliculi. So let's first label this. This is the lower puncta. This one is the upper puncta. Lower canaliculi, upper canaliculi. Finally coming to common canaliculi, which opens into, this is the lacrimal sac, then nasolacrimal duct. Nasolacrimal duct, and this nasolacrimal duct opens into the inferior, this was your exam question, inferior meatus of nose. Make a Q and write inferior meatus of nose. NLD opens into the inferior meatus of nose. We should have made the NLD little more narrower, no? It's a little more thicker. Let's repeat the diagram. I don't like this diagram. Let's make a little better one once again. So upper puncta, lower puncta, upper canaliculi, lower canaliculi, common canaliculi, lacrimal sac, nasolacrimal duct opening into the inferior meatus. So that's it. Better one. Okay. Now this was the common canaliculi. This is the lower and this one is the upper canaliculi. So first question we discussed is that NLD nasolacrimal duct opens into inferior meatus. Now another important thing. Watering in the eye is of two types. Let's learn like this, that watering is of two types. What are the two types of watering? One when there is overproduction of tear and one when there is overflow of tear. So when there is overproduction of tear, we call it lacrimation. Overproduction of the tear, we call it lacrimation. And when there is overflow of the tear, what do you call it? Epiphora. Epiphora. So watering can be a lacrimation, watering can be epiphora. So now whenever there is a blockage in the drainage system, pay attention. Whenever there is a blockage in the drainage system from lower or upper canaliculi, common canaliculi, sac, NLD, whenever there is a blockage, there will be watering, and this watering is nothing but epiphora. So what are the clinical features? See, it's very simple. We will learn it as ED. Wherever there is a blockage, manifestation is same, epiphora and discharge. So ED, epiphora and discharge. Okay. Why there is discharge, you all understand? There is stagnancy, so there will be infection. So epiphora and discharge. Now we talk about investigations related to lacrimal drainage system. Investigations. Give the heading. First is regurgitation test, which means that if you press at the medial canthus, water and discharge comes out. Regurgitation test. Only it will come out if it is blocked, not otherwise, of course. So that is regurgitation test. I repeat, pressing on the medial canthus causes regurgitation of discharge and water due to blockage. Second is syringing. What is syringing? We all know very well. Let's understand here. Pay attention. We are injecting water in the lower puncta. If everything is fine, water will come from the nose, from this nasolacrimal into the nose, and from the nose into the mouth. So you ask the patient whether there is water in the mouth has reached. If he says yes, well and good. If no, that means there is some blockage. This is what is called syringing. That was one role of syringing, which is what? That it is answering you this question, that whether there is a blockage or not. What is the second role? Second role is it will give you the idea of where is the blockage. Let's see how. Again, first listen all of you. This is the diagram in front of you. If there is any blockage at the CC level or a SAC level or an LD level, can you see this? Any water you have injected will return from upper puncta. This is the upper. So when the regurgitation is from upper puncta, that means the blockage is anywhere from CC, common canaliculi, to SAC or NLD. But suppose now that there is a blockage on the same canaliculi, the blockage is here. So what, when you inject the water, what will happen? It will regurgitate from the same puncta. Okay, so that means this syringing is telling us, at what level the blockage is. It is also helping to know at what level the blockage is. And is there any third role of syringing apart from these two? It has answered your question whether there is a blockage or not, where is the blockage, and the third role of syringing is used as a treatment of partial obstruction. Pressure syringing is done. Pressure syringing is done for treatment of partial obstructions. Next test is Jones dye test. Just mug up the name. There are too many steps. We never learn it. From years we are not learning. Nobody asks us. Where will you make a mistake? I'll let you know. The only mistake that you'll make is that Jones dye test is not a test of dry eye. Always remember that. That is why you all mark. That is what you all mark. So, it is not a test of dry eye. Jones dye test is a test of lacrimal drainage system. That's it. Jones dye test, it's a test of lacrimal drainage system. What is the next investigation? Dacrocystography. Dacro means lacrimal, cysto means sac, graphy means to study. Studying the lacrimal sac. Dacrocystography. So what you do here? You put a dye in the tear and then you follow and take an X-ray. So think yourself, if there is any stone in the sac, any tumor in the sac, any tuberculosis in the sac, you will see it as a filling defects. We can see it as a filling defects. So this is what we mean by dacrocystography. And if the dye that we are using is a radioactive dye, we call it dacryoscintilography. Now we call it dacryoscintilography. Rohtak, DCG is when you put a dye in the tear, naturally the dye will flow with the tear, and now you take a radiograph here and see and study the sac. So suppose there is any lesion inside the sac, naturally that will be seen as a filling defect. This is what is dacrocystography, that is studying the lacrimal sac. And if instead of a normal dye I use a radioactive dye, now I call it dacryoscintilography. So we follow the dye with a gamma counter in case of dacryoscintilography. I repeat, if the dye is radioactive dye, now this investigation is called dacryoscintilography. So we all know this. What is lacrimal drainage system? When it is blocked, how will the patient present? What are the investigations? Now give the heading dacryocystitis. Now you know what it is. Dacryocystitis, write down, is inflammation of lacrimal sac. Dacryocystitis is inflammation of lacrimal sac. Let's classify it into two. It can be congenital or acquired. And any acquired is further divided as acute or chronic. Congenital and acquired, which can be divided as acute or chronic. First we talk about congenital dacryocystitis. Give the heading congenital dacryocystitis. What will be the etiology? Okay, first listen all of you. Do you all know during embryonic development the nasolacrimal duct canalizes? Okay, so if it fails to canalize, there is a blockage in NLD leading to congenital dacryocystitis. So just remember this much. Etiology, it is due to non-canalization of NLD. or you can say the blockage is at the NLD due to non-canalization. How will the child of present? So what are the clinical features of congenital? Again very simple. ED, epiphora and discharge. Epiphora and discharge. Treatment. How do you treat a congenital dacryocystitis? Now the treatment is exam question. Make a cue there all of you. If the patient is less than 6 months, the best treatment you all know is antibiotic drop with massaging. When you massage, you are increasing the hydrostatic pressure of the NLD with antibiotic eye drops. Massaging with antibiotic eye drops. We are increasing the hydrostatic pressure of the nasolacrimal duct. Please note down, this is called Krigler's massage. Now, if your patient is between 6 to 18 months, your best results will come with probing. And more than 18 months, the best result is from DCR. So, what is DCR? Dacrocysto, that means sac, rhinostomy. Let's understand what is DCR. I'll make the figure again for you all. Let's explain what is DCR. Common canaliculi, this is the sac and this is the NLD. Okay. Now what I'm saying is this is the nose. So dacrocysto means sac. You make two flap of the sac, cut the bone in between and join it with two flap of nose. So this is dacrocysto rhinostomy, connecting the sac with the nose. Dacrocysto rhinostomy. Pay attention, another exam question here. Where do you make the opening in DCR? You will answer this time it is middle meatus. So in DCR we make the opening in the middle meatus. And one more thing, I want to make it very clear to you all. This data which I have given is not a hard and fast rule. Okay, suppose a child of 7 months comes to my OPD, that doesn't mean I will go for probing. I may still try massaging. This data is saying that the success of the procedure is best in this age limit. So you have to answer in your question paper, you have to answer according to this only. Okay, that the success of this procedure is best in this age limit. There is one more question from congenital dacryocystitis, and what they ask you is, when does the tear production start? In a small child you will answer 6 weeks. Tear production starts at 6 weeks. Now Ludhiana, this one we are talking about reflex tear production, because think yourself, a small child when born doesn't have dry eye, but when he cries there is no tearing. So that is when he cries and he starts tearing only at around 6 weeks of age. So this is what we are talking about. Next we talk about is acquired dacryocystitis. We will first take acute dacryocystitis. It's very simple. Think yourself. How will a patient of acute dacryocystitis present? Again epiphora, discharge and all the signs of acute inflammation, redness, pain, tenderness and so on. Easy to learn. And therefore how to treat the acute? Start with antibiotics and anti-inflammatory. Antibiotics and anti-inflammatories. Okay, and when the inflammation is subsiding, we go for DCR. When inflammation subsides, we go for DCR. Next important thing here is, exam question that they ask you is, what is a sequelae? Make a Q and run. Any acute, if not treated, will lead to lacrimal fistula. Lacrimal fistula. Okay. So don't be an impression that chronic causes lacrimal fistula. It is a sequelae of acute dacryocystitis. And then coming to that, what is the treatment of lacrimal fistula? Please don't answer fistulectomy. It is a wrong answer. Okay. So what are you going to answer? You will answer DCR. So treatment of lacrimal fistula, again you answer DCR. Good. Next we talk about another exam question. What is the most common etiological agent of acute dacryocystitis? You will answer Streptococcus hemolyticus. Streptococcus hemolyticus. And if this option is not given, the second best option is Staph aureus. Second best option is Staph aureus. Now give the heading chronic. Chronic dacryocystitis. Very simple clinical features, epiphora discharge. Treatment DCR. So clinical feature, epiphora discharge. Treatment DCR. Let's discuss some exam questions. So the first exam question is, it is more common in females. It is more common in females. Next question, what is the most common etiological agent? Now you answer Streptococcus pneumoniae. Streptococcus pneumoniae. Next question, what is the sequelae of chronic? So any chronic dacryocystitis will cause mucocele formation. And of course, as you know, it will get infected, causing pyocele formation. And then there is lacrimal fibrosis. Okay, think yourself, in lacrimal fibrosis, the two walls of the sac adhere to each other. So there is no lumen in the lacrimal sac, means you can't do DCR. So what is the treatment of lacrimal fibrosis? You will answer DCT. It is dacrocystectomy. Cut the lacrimal sac. So that is what we do. We just cut the lacrimal sac. That is, we go for dacrocystectomy. So we have covered all the questions from this chapter. There is another very important question. Let's solve a few more important exam questions. What is the most common, keep writing the question all of you, what is the most common ocular manifestation of, what is the most common ocular manifestation of mumps? Most common ocular manifestation of mumps. Bilaspur, I don't give break before 3 hours. Okay, and I've broken my rule last time, I can't do it again. We have to study a lot, and anyway we are going very, very slow. So please study. So most common ocular manifestation of mumps, you will answer dacryocystoadenitis. Dacryocystoadenitis. So it is inflammation of both sac as well as gland. Inflammation of sac and the gland. Next question. What is the most common ocular manifestation of measles? What should you answer? Give me the answer, Bilaspur. Most common ocular manifestation of measles. Come on, all those who are thinking of break, answer this. I'm waiting. Fast. Measles, think yourself, what will it present in the eye? Most common ocular manifestation of measles, what will you answer? Very good, Batinda. Yes, it is vitamin A deficiency. Vitamin A deficiency. Okay? Yes, Ludhiana, you're right. There is another very important question. Give the heading snow blindness. What is snow blindness? What is snow blindness? It is also called photophthalmia. Hope you all are writing. It is also called photophthalmia. It is injury to the eye by ultraviolet rays. Again, which ultraviolet? It is UVB. So, injury to the eye by UVB rays. So, why are we calling it snow blindness? Because this injury is possible only when you go in the snow. The ultraviolet rays are reflected from the snow, comes into your eye and damage your eye. So, we call it snow blindness. What does it cause in the eye? What are the clinical features? You will write down corneal epithelial erosion. So, there is a corneal epithelial erosion. It's a very, very painful condition. Corneal epithelial erosion. How to treat this problem? Pad and bandage with antibiotic ointment. Pad and bandage with antibiotic ointment. Okay, so that is snow blindness. Next question, write down. Next question, all of you write down. What is photoretinitis? What is photoretinitis? So, photoretinitis is injury to the eye by infrared rays. This time it is infrared rays. This will occur if you directly look at the solar eclipse. If you are very superstitious, you directly look at the solar eclipse because of some superstitious reasons, without using an aid, you will get this photoretinitis. And what does this infrared ray cause? Clinical features. Clinical features. It causes macular burn leading to macular scar. Causes macular burn leading to macular scar. Naturally, if there is a scar, no effective treatment. There won't be any effective treatment. So, no effective treatment. Okay? Now we come to, so these were some of the very important exam questions. Yeah, we have already discussed the cause of nyctalopia. So, we have covered this. Turn the page, give the heading uveitis. Turn the page, give the heading uveitis. So, you all know what is uveitis? Write down inflammation of the uveal tissue. Uveitis is inflammation of the uveal tissue. And what is the uveal tissue? Iris, ciliary body and choroid. Just made the diagram for you all. Iris, ciliary body and choroid. We can classify this uveitis anatomically, write down. You can classify it anatomically if you talk of classification, or pathologically. Anatomically, if you talk, any uveitis can be number one, anterior uveitis. What is anterior uveitis? Please pay attention, because here you make a little mistake. It is inflammation of iris and also pars plicata. This is anterior uveitis, both iris and pars plicata, and therefore we also call it iridocyclitis. Cyclitis. Then second type is intermediate uveitis. Intermediate uveitis, this is involvement of pars plana. Intermediate is pars plana inflammation, so you also call it pars planitis. We also call it pars planitis. Now what we are left with is choroid. So that is posterior uveitis. That is choroiditis. And if all the three parts are inflamed, we call it panuveitis. When all the three parts are inflamed, we call it panuveitis. So in this diagram, this one is anterior, this is intermediate, this is posterior uveitis. That is a choroid. Pathologically, let's learn pathologically. Uveitis can be granulomatous or non-granulomatous. Exam question, what do you mean by granulomatous? Make a Q and learn. Make a Q, all of you. Granulomatous inflammation, write down, is intense inflammation. Granulomatous is intense inflammation leading to nodule formation. So it is an intense inflammation leading to nodule formation. And what about non-granulomatous? Ambala has some problem of notepad. Non-granulomatous, just the opposite. You have to just learn that it is just the opposite. Ambala, is it fine now? So just the opposite means inflammation not intense, so no nodule formation. Inflammation is not intense and no nodule formation. This is what? Non-granulomatous. Okay? Now another exam question, please note down. Iris is weakest. What is the weakest part of the iris? So please remember, iris is weakest at its root, where it is attached with the ciliary body. So this is the weakest part of the iris. This was asked in the exam. And if this iris disinserts from its root, we call it iridodialysis. If it disinserts from its root, we call it iridodialysis. Any disinsertion from the root is called dialysis. So this is iridodialysis. So look at the diagram, all of you. If this part of the iris is suppose disinserted, what happens to the pupillary shape? It becomes D-shaped pupil. It will become something like this. So this is your exam question. So write down, pupil becomes a D-shaped pupil. It's a D-shaped pupil. In iridodialysis, it's a D-shaped pupil. There is no audio for Vishakhapatnam. देखो तो. Okay, Vishakhapatnam, we are taking care of. Anyway, you must not be able to hear me also. Rohtak, D-shaped in the sense you have to be little imaginative here, that if suppose this part is disinserting from its root, okay, so this curvature is gone. If this curvature is gone, it's replaced by a straight line, the whole pupil now becomes D-shaped. Right? If you can understand, it's good, otherwise you just mug it up. In iridodialysis, the pupil is D-shaped. Can you get it, Rohtak? See, this part is disinserted. So this curvature of the pupil is disturbed. Now it becomes a straight line. And therefore, only this curvature is left. So it becomes a D-shaped pupil. Just remember, in iridodialysis, the pupil is D-shaped. It's an exam question. Make a Q, all of you. Vishakhapatnam's problem is solved? Okay, next we talk about is after this classification of uveitis, give the heading anterior uveitis. Anterior uveitis. Clinical features. The patient of anterior uveitis will present with the 5 fingers. And what are the 5 fingers? Again it is the same, pain, redness. Now can you tell me which type of redness you will get in anterior uveitis? Answer me. Then photophobia, blepharospasm and discharge. Which type of redness in uveitis? Yes, very good. It is always a ciliary congestion. It's a ciliary congestion. And which type of discharge? It is always watery discharge. इसका ऑडियो प्रॉब्लम. Okay. I think now Vishakhapatnam, your audio problem is over. I was waiting for that. Now let's continue. What I said is anterior uveitis. These are the 5 main features the patient presents with. That is pain, redness, photophobia, blepharospasm and discharge. As I said, redness is ciliary congestion and discharge is always a watery discharge. Now coming to on-examination findings. Let's learn the on-examination findings. All of you please make this figure, it's very important. Make the figure, all of you. There is a list of on-examination findings in anterior uveitis. I will change the page, I think that will be better for us. What are the list of findings? First of all, write down KPs. What are KPs? Okay, let us make the figure. Let us make the figure first. Iris, ciliary body. Vishakhapatnam, it's okay now? Sorry, this should be here. And then comes the, good. Then we talk about the retina, this is the lens, this is the suspensory ligaments. Okay, now let's start. First feature is KPs, keratic precipitates, number 1. Now, in non-granulomatous, These keratic precipitates are fine and grain color. And you all know that if it is granulomatous, what happens? In granulomatous, these are large KPs with greasy look, which is called mutton fat KPs. We call it mutton fat KPs. I am repeating. KPs in granulomatous are large with greasy look. This is called mutton fat KPs, whereas in case of non-granulomatous inflammation, it is fine and grain color. What are KPs? They are nothing but proteinaceous deposits at the back of the cornea. Now pay attention, very important point here. KPs are always seen on the lower half of the cornea. They are never found on the upper. So if I make the cornea like this in front of you, the KPs are maximum at the lower half in a triangular area, and this area where the KPs are maximum, this is called arch, the same arch which we learnt as arch line, this is called arch triangle. Okay, so you should know what is arch triangle. Arch triangle is area on the cornea where the KPs are maximum. Now coming to why are the KPs always on the lower side and why not on the upper part of the cornea? The answer is due to convection currents in the aqueous. Aqueous has convection currents, so these deposits are always deposited on the lower half. Okay. Now next feature is inflammatory cells on in the anterior chamber, and what you call is aqueous cells. So the second is aqueous cells. Then there can be haziness in the anterior chamber, and this is called aqueous flare. Haziness, do you all remember your 12th class physics Tyndall effect, where when you are looking through the light also early morning, you can see those dust particles all moving. So this is what we taught. This is the same haziness you are able to see even here in the anterior chamber, that is according to Tyndall's effect. So this is aqueous flare, and it is due to the leakage of protein. Why you are getting is important, you should know. It is due to the protein leakage. So this is your aqueous flare. What is the next finding? Next finding is edema in the iris. So the iris lines are all obliterated, it becomes smooth, and so we call it muddy iris. Muddy iris. That is M. I am not able to write it. Yeah, now. So muddy iris. So edematous iris is called muddy iris. Next point, as I have already talked about in the earlier lecture, meiosis. In uveitis, it is always constriction of pupil, that is meiosis. And what did you tell me all, that if there is granulomatous inflammation, there can be nodules? Pay attention. Either the nodules are at the base of iris or the nodules are at the pupillary border. At the base, B for B, it is called Basaka nodule. B for B, we call it Basaka nodule. And at the pupillary border, you all know we call it Cope's nodule. Cope's nodule. We are still not over with the features. There are few more features. Let's see what they are. After this, so what you have learnt, I'll just revise it for you all so that you don't get confused. One was KPs, then aqueous cells, aqueous flare, muddy iris, meiosis, and nodules. Next, if I am not treating it, there is adhesion of the iris to the lens, and this is what you call as posterior synechia. So this is posterior side. If this is the iris, make this figure also, all of you. Make this figure. Now pay attention. All of you look up at the screen. Posterior synechia means when the iris is adhering to the lens. Now this synechia can start somewhere. Suppose it starts here or it starts here, right? If I treat it, it will not extend, but if I don't treat it, inflammation is increasing and there will be a stage when whole pupillary border sticks on the lens. When the whole pupillary border sticks on the lens, this This whole synechia which is formed all around the pupil is called ring synechia. Now we call it ring synechia. Ring synechia is also called, what is the other name? Seclusio pupilli. We also call it seclusio pupilli. Now let's come back to this diagram and understand, very important. If there is a ring synechia, if there is seclusio pupilli, can you understand that aqueous will not be able to flow anteriorly because now this whole thing is adhered to the lens. So if the whole thing is adhered to the lens, aqueous cannot flow, it starts collecting in the posterior chamber. Keep looking up. Any collection in the posterior chamber will push the iris forwards, and this bowing of iris forward is called, anyone fast? Bowing of iris forward is called iris, very good Vishakhapatnam, it is Bombay, iris Bombay. And think yourself, look at the figure again, let's concentrate. Any iris Bombay, there will be adhesion with the cornea. Because it's already inflamed, it is nearer to the cornea. So now when the iris adheres to the cornea, we call it sorry, now we call it anterior synechia. So now here we will write, this will lead to peripheral anterior synechia and this is called in what? Angle closure glaucoma. As you can see, any peripheral anterior synechia is finally leading to angle closure glaucoma. Angle closure glaucoma. Let's revise. Posterior synechia causing ring synechia leading to pupillary block. Any pupillary block means collection of aqueous, bowing of iris forward leading to iris Bombay, which causes peripheral anterior synechia, and that leads to angle closure glaucoma. Hope everyone is clear about that. Rohtak, Bombay spelling is not B-O-M-B-A-Y, okay? It is B-O-M-B-E. Koi baat nahi, correct yourself now. Now coming back to, look here, all of you pay attention again. When only the pupillary border was sticking on the lens, I called it ring synechia. But now suppose there is a condition where the whole surface is also filled by fibrous tissue. Now this condition is called occlusio pupilli. So when everything is filled with fibrous tissue, we call it occlusio pupilli. We are left with last feature here. Let's mention it, that also in some patients you can get an inflammatory membrane. Just what is pars? Bhatinda pars means peripheral anterior synechia. So it's an anterior synechia. Lastly, you can get an inflammatory membrane behind the iris. This is called cyclitic membrane. Inflammatory membrane behind the iris. This is called cyclitic membrane. So these are the features of anterior uveitis. Jammu, occlusio means it is not only the border which is sticking. If there was a pupil is like this, right? So if the pupillary border is just adhering to the lens, it was ring synechia. But suppose the whole lens surface is also filled with fibrous tissue. Naturally, this fibrous tissue will be growing on the lens surface also. So this whole thing is now covered with fiber, the red which I show you in red. So this is what is called occlusio pupilli. This is what is occlusio pupilli. Which membrane, Ambala? It is cyclitic membrane. This is an inflammatory membrane behind the lens, sorry, not behind the lens, behind the iris in front of the lens. I have shown it in black here. This is cyclitic membrane. Okay. Now coming to, done. Now treatment of anterior uveitis. How do you treat anterior uveitis? Treatment. This is exam question. Make a cue. What is the drug of choice for treating anterior uveitis? You will answer steroids, topical steroids. It is still topical steroids. And along with that, what else you give is topical cycloplegics. We also give topical cycloplegics. Exam question, what is the role of cycloplegics? What is the role of cycloplegics? First, there are many roles. Let's learn all the rules. First, it gives rest to ciliary muscles. It gives rest to ciliary muscles. Second, it relieves pain. It relieves pain. Third, prevents posterior synechia. And fourth, it breaks the posterior synechia. Rest to ciliary muscles, relieves pain, prevents posterior synechia and breaks the posterior synechia. Okay? Now pay attention all of you. I hope you all are listening to me. There was an exam question where all these four were given as options. All four are correct. What should you mark? Mark the first one. Okay? So if they ask you this way, you will first, the most important is if the part is getting the rest, the inflammation will subside. So give rest to ciliary muscles. Another question, what is the sign of active inflammation in anterior uveitis? I repeat the question, what is the sign of active inflammation? What is the sign of active inflammation in anterior uveitis? You will answer aqueous cells. So, a patient with aqueous cells means the inflammation is active. KPs are not the sign of active inflammation. KPs can be old and pigmented. They can be just the sign of old inflammation also. They can be sign of fresh inflammation also. But when there are aqueous cells, it is always a fresh inflammation. It's an active inflammation. There is another very important exam question here asked last year in your exam. I hope you all are listening. What is Luminate program? What is Luminate program? Now this program is a study by Lux Biosciences, which is a company, medical company. So Lux Biosciences is studying a alternative drug which is non-steroidal for treating anterior uveitis. They ask you which drug. The drug is a immunomodulator, that is voclosporin. I'll repeat everything what I said. I said Luminate program is a study to find a non-steroidal treatment of anterior uveitis. Even till today the choice of treatment is steroids because we haven't found a drug which controls uveitis better. But as you know, steroids have its own complications. So there is a study going on for a non-steroidal treatment of anterior uveitis, and this drug is, this is what they asked, which drug is being studied? It is voclosporin. It is an immunomodulator. Okay, next question. What is a hallmark feature of uveitis? If they ask you something like this, hallmark feature of uveitis, now you should answer KPs. Typical of uveitis is always KPs, keratic precipitates. Good. Now give the heading intermediate uveitis. We will take a short break and about 15-20 minutes break and then we continue. Just give the heading intermediate uveitis. Let's take a break. called pars planitis. Okay. What are the clinical features? Please pay attention. This time those 5 fingers will not fit in. So how does a patient present as only blurring of vision, and he is generally a male patient of young age. So let's learn like this. A young male presenting with, so it's a disease of young males, presenting with unilateral blurring of vision. So, patient, young male presenting in my OPD with unilateral blurring of vision, I should check for pars planitis. So, this is the presenting feature, that is okay, unilateral blurring of vision in a young male. This is how it presents. Coming to on examination, let's make a diagram, all of you. We said that this is an inflammation of pars planitis, right? So, pars planitis means this area. So, the first feature that you will see is inflammatory cells corresponding to pars planitis, and this is what you call retrolental flare. Retro means behind the lens, so it is retrolental flare. Second, after retrolental flare, number 2 is few KPs. Compared to anterior uveitis, KPs are few. So, few KPs. Third, inflammatory exudates floating in the vitreous. These are called snowballs. So, white exudates floating in the vitreous, they are called snowballs. And an inflammatory membrane over the pars plana, this is called snow banking. This is called snow banking. All of you make a cue here. Snow banking is a pathognomic feature of pars planitis. Snow banking is a pathognomic feature of pars planitis. Okay, so the same inflammatory exudates floating are called snowballs. When they are on the pars plana, we call it snow banking. Coming to the treatment part, how do you treat a intermediate uveitis? First, very important, it is a self-limiting disease. So, the indication of treatment is only when vision goes less than 6/12. Indication of treatment is if the vision is less than 6/12. Otherwise, please don't treat it, it will be treated by its own. It is self-limiting. But if vision goes less than 6/12, it indicates what? That this patient has associated cystoid macular edema, and that is why his vision is so less. So, this inflammation has finally affected the macular area. So, now what to do? We go for a 4-step approach. Step 1 is local steroids. Think yourself, how will you give local steroids? Eye drops will not reach behind at the pars plana. So, what we do is we give subtenons. I taught you tenons capsule. So, subtenons injection of TA. What is TA? Triamcinolone acetate. Subtenon injections of triamcinolone acetate. Second is systemic steroids. Second is systemic steroids. If your local steroid is not effective, go to step 2. Step 2 is add-on, it's all add-on. That means 2 means 1 and 2. Step 3 means 1, 2 and 3, okay? And what is step 3? It is cryotherapy. Cryotherapy. Let's understand what is cryo doing in this inflammation process, how it is helping is. I have just taught you what is snow banking. We are giving cryo corresponding to this snow banking, this inflammatory membrane, so that it damages the blood supply of this inflammatory membrane. So, cryo is damaging the blood supply of the inflammatory membrane so that the inflammation is curtailed. So, this is the main source of inflammation. What is step 4? Step 4 is pars plana vitrectomy. Step 4 is pars plana vitrectomy. So again, what is the role of vitrectomy here? It's an inflammation. So what is happening? Whatever retrolental flare, because of these inflammatory cells, the patient's vision is blurred. So when you are cutting it off, what is happening? The visual axis is clear, patient sees clearly. Second advantage, first advantage, the blurring of vision is solved. Now patient can see clearly. And second advantage is, it reduces the inflammatory bulk. So now your patient will respond better with steroids. So it reduces the inflammatory bulk so that your patient responds better with steroids. Next we talk about is so that was intermediate uveitis. Now we talk about posterior uveitis. Posterior uveitis. Now posterior uveitis we just said is choroiditis. Now let's understand before writing, all of you first listen. Choroid is not the only one which is inflamed in posterior uveitis, but all the joining structures to choroid is also inflamed. For example, when there is choroiditis, there will be retina involvement. Any retina involvement means increased capillary permeability in the retina leading to leakage. So you will get edema at the macula, edema in the retina, then vitreous involvement, then optic disc involvement. So all the joining structures are involved. So what are the features of posterior uveitis? First you will write, now write down, choroiditis. Okay, Bikane, what about now? Is the voice better? Choroiditis. These are seen as round yellow patches. Choroiditis is seen as round yellow patches. Choroiditis is seen as round yellow patches. Second is vitritis. Third, papillitis, that is involvement of the disc, papillitis. Next is cystoid macular edema. Retinal edema. Periphlebitis. Periphlebitis. What is periphlebitis? Inflammation of veins. Inflammation of veins. So how do I know that this vein is inflamed? If there is periphlebitis, this vein is covered with inflammatory exudates all along its length like this. And these inflammatory exudates covering the vein, this is called venous sheathing. This is called venous sheathing. Okay, so these are the features of posterior uveitis. Talking about treatment. First is again local steroids in the same way, that is subtenon injection of triamcinolone acetate. Local steroids, that is subtenon injection of triamcinolone acetate. And if it doesn't work, we go for systemic steroids. If it doesn't work, we go for systemic steroids. Okay, now pay attention. We have talked about uveitis, we have talked about anterior, intermediate, posterior uveitis, right? What are the features, what is granulomatous, what is non-granulomatous. Now the most important part of this chapter where maximum questions are asked is what are the diseases associated with uveitis. So give the heading diseases associated with uveitis. So now I have made things easy for you. We will just learn point wise, and suppose I tell you in this condition you get a granulomatous panuveitis. You know what is granulomatous, you know what is panuveitis. So you don't have to learn the features again. Suppose I say in this condition you get non-granulomatous anterior uveitis. Again you know what it means. So now we learn, and everyone just put it in the box. The type of uveitis, if I tell you, just make a box, you will learn better and nicely. Let's see. First is diseases associated. First is arthritis. Arthritis, very important first point. All these arthritis associated with uveitis are HLA-B27 associated. Exam question. Number 2, they are all seronegative. They are all seronegative. That means rheumatoid factor is absent. Rheumatoid factor is absent. Number 3, what are these? What is the type of uveitis in these arthritis? Type of uveitis in these arthritis. Very important, all of you please make a box. It is non-granulomatous anterior uveitis. It is non-granulomatous anterior uveitis. Now let's name these arthritis. First is ankylosing spondylitis. Ankylosing spondylitis. Second is psoriatic arthritis, and third is Retter's syndrome. So what is Retter's? It is a triad of, Retter's is a triad of, yes, I think you all know this, arthritis, urethritis and conjunctivitis. So in triad you don't have uveitis, it is conjunctivitis, but of course you get uveitis also. And what is the fourth type of uveitis associated with, fourth type of arthritis associated with uveitis? It is JRA, juvenile rheumatoid arthritis. Now pay attention, we have to elaborate on JRA. It is defined as any arthritis in less than 16 years of age. Any arthritis in less than 16 years of age. It is of 3 types. Pauci-articular, where less than 5 joints are involved. Then polyarticular, more than 5 joints are involved. and systemic onset. This systemic onset is also called Still's disease. Systemic onset is also called Still's disease. Okay, all of you pay attention here. It is only this pauci-articular JRA which is associated with uveitis. Okay, pauci-articular JRA. So total description would be pauci-articular seronegative. Pauci-articular seronegative. Another important thing I am adding to your knowledge here, this is also, any JRA can be early onset or late onset, you have to answer. Uveitis is seen in early onset pauci-articular. Early onset. So this pauci-articular can be early or late onset. Uveitis is in early onset pauci-articular JRA. Okay. This is a very important cue. Make a cue there. Now listen. You have just read that it is which type of uveitis in arthritis? Non-granulomatous anterior. Right? So anterior uveitis patient, what have we learned? How do they present? 5 fingers, pain, redness, photophobia, blepharospasm and discharge. In JRA, these 5 fingers are absent. No pain, no redness, no photophobia, no blepharospasm, no discharge. Therefore, this is atypical anterior uveitis. We call it atypical anterior uveitis. Are you getting me? So, any anterior uveitis with no 5 fingers are atypical anterior uveitis. And because there is no redness, uveitis of JRA is called white uveitis. Because of no redness, this uveitis on JRA is also called white uveitis. Correct? This is very important. Now keep thinking. If you say it's a white uveitis, there is no problem to the patient, why will he come to me? The child will never present to me. So what is the presenting feature in this patient? The patient comes with complications. So this is again important. What complications can occur in patients of JRA? Let's learn it this way. My first chapter, cataract. So complicated cataract. Second chapter, glaucoma, secondary glaucoma. Third chapter, cornea. So band-shaped keratopathy. Do you remember that? Please all of you, whenever you attend my class, make your notes very thorough. अच्छे से याद किया. Just learn them nicely when you enter for the next class. So if you remember in cornea, I taught you as etiology of band-shaped keratopathy to be chronic uveitis in JRA. So it will present as complicated cataract, secondary glaucoma and band-shaped keratopathy. This is again exam question. So that was about arthritis. What is the next disease associated? The next disease associated is, after arthritis, write down sarcoidosis. Sarcoidosis. You all know what is sarcoidosis. If you have forgotten, revise it from your medicine. It is a granulomatous inflammation involving multiple organs. Because it is granulomatous, there will be nodule formation, right? So sarcoidosis in the eye presents as what? Let's see from outside to in. Let's think outside to in. There are sarcoid nodules on the sclera and episclera. Sarcoid nodules on the episclera and sclera. Okay? Then second, what next? On the cornea, if you remember, I taught you interstitial keratitis. Then in the cornea, I taught you due to hypercalcemia, it can lead to band-shaped keratopathy. Band-shaped keratopathy. What next? Uveitis. Now all of you make a box again. This was your exam question. What type of uveitis occurs in sarcoidosis? It is granulomatous panuveitis. It is granulomatous panuveitis. Okay? Now listen. If it is a panuveitis, there will be posterior uveitis also. So if it is so, it can always be associated with periphlebitis. Now pay attention. In sarcoidosis, when there is periphlebitis, the venous sheathing is very thick like a candle wax, and this is what is called candle wax drippings. This is what is called candle wax drippings. Exam question double Q. So 2 questions from sarcoidosis. Type of uveitis, it is granulomatous panuveitis. Okay. What are candle wax drippings? Or they will ask you, candle wax dripping is a feature of, I hope you are making all the rough diagrams that I am making. Candle wax dripping is a feature of, you will answer periphlebitis. Next association is Behçet's disease. Behçet's disease. Again, it's an autoimmune disease. It's a obliterative vasculitis, right? If you have forgotten, please revise it from your medicine. What is Behçet's disease? Let me revise it for you. There are oral ulcers, genital ulcers, positive skin test, and eye involvement. So just go through that. We will be concerning ourselves with eye involvement. So Behçet's disease actually presents with, okay, first question let's first understand is HLA association. So this one is HLA-B5. So these are the 2 associations you will learn, one for arthritis, one for Behçet's. Number 2, what is the type of uveitis? All of you in the box. It is again non-granulomatous, but it is not a panuveitis. It is either anterior or posterior. So it is non-granulomatous, either anterior or posterior. It is also called transient hypopyon syndrome. Transient hypopyon syndrome because of recurrent hypopyon, because there can be recurrent hypopyon. There is recurrent hypopyon, so we call it transient hypopyon syndrome. So these are the 3 main points of Behçet's you will remember. Next association is HIV. Next association is HIV. Talking about HIV, first very important double Q, what is the most common ocular manifestation? Now this is the question open to all of you, let me see some answers please. What is the most common ocular manifestation of HIV? I'll wait. First, what is the most common ocular manifestation of HIV? No answers. Most common ocular manifestation. Okay, many of you are answering CMV retinitis, which is wrong. That is what is a trap, and that's why I asked you. Okay, it is not CMV retinitis. You will answer CMV retinitis if the question was what is the most common opportunist infection of HIV, then your answer would have been CMV retinitis. Okay. Now what you will answer here is yes, Ludhiana, it's a microangiopathy. So ultimately what is the answer here is that it is HIV induced microangiopathy. HIV induced microangiopathy. So in microangiopathy means pathology of the small blood vessels. What are the features of this angiopathy? Number 1, there are hemorrhages in the retina. Then there will be soft exudates which are called cotton wool spots. They are soft exudates. cotton wool spots. What are the soft exudates composed of? And what are hard exudates composed of? Anyone? Soft exudates are the indicator of hypoxia. They are axonal debris. Actually, soft exudates or cotton wool spots are nothing but axonal debris, dead axons. And the third feature of microangiopathy is microaneurysms. Microaneurysms. So this is the most common ocular manifestation, that is microangiopathy, with hemorrhages, cotton wool spots and microaneurysms. Okay. Now among the three, if all are mentioned, what should you answer? It is cotton wool spots. It is always cotton wool spots. Okay. Another important thing here that we'll discuss, microaneurysms. Now this is not related to HIV, but let's discuss it so that we learn better. Where else do you find microaneurysms in the retina? Where have you learned, all of you? Most common pathology where you have learned microaneurysms fast? Diabetes, right? Very good, all of you. So it is diabetes. So what about macroaneurysm? Yes, all of you have answered me correctly. It is diabetes. Now what about macroaneurysm? So please remember, microaneurysm, make a box and write because it is a separate information. Microaneurysm is seen in diabetic retinopathy, but macroaneurysm, this is seen in hypertensive, very good Shimla, it is hypertensive retinopathy. So macro means any aneurysm of more than 100 microns is macro. Okay, so this is in hypertensive. And of course we have learned that microaneurysm is in DR, microaneurysm is also in HIV. Come to the next question after this. What is the most common opportunist infection of HIV? I am talking ocular again. And this is again, now you will answer, most common opportunistic infection is CMV retinitis. As you all have already answered, yes Shimla, it is CMV retinitis. Now, next double Q, how does CMV retinitis present in the eye? How does the CMV retinitis present in the eye? This is a very common question, so I am waiting for the answer. CMV retinitis, how does it present in the eye? Come on, try it. Okay, why are you all only typing? Yes, okay. Yeah, Ludhiana, it is sauce and cheese retinopathy. Sauce and cheese retinopathy. Okay, so sauce is the hemorrhage, cheese is the necrosis. This is asked in the exam, sauce and cheese retinopathy. Good. Now we talk of what are the other opportunist infections apart from CMV, which is the most common. Other opportunist infections, give the heading. Other opportunist infections are, number 1, toxoplasmosis. Toxoplasmosis. Then Pneumocystis carinii. Pneumocystis carinii. Now both toxoplasmosis and Pneumocystis carinii, they primarily cause choroiditis. They are causing choroiditis. And the third is herpes zoster. And in patients of HIV, herpes zoster can lead to ARN, which stands for acute retinal necrosis. Acute retinal necrosis. Okay. Now give the heading toxoplasmosis. The next association is toxoplasmosis. toxoplasmosis can present either as anterior uveitis or posterior uveitis, either as granulomatous uveitis or non-granulomatous. So what I am trying to say here is any combination permutation is possible. Ludhiana, type of uveitis in HIV will depend also upon what are the associated secondary infections that are taking place. But if you still want to choose between granulomatous, purely if I talk of HIV, it has to be non-granulomatous. It is still non-granulomatous, but again the clinical picture in HIV will depend upon opportunist infections associated with it. Okay? So coming back to, if it is toxoplasmosis, it can be either anterior or posterior, granulomatous or non-granulomatous. But in the whatever you have missed will be taken care of. It's not possible to repeat whole topics, okay? We will take care of whatever you have missed, just make a note of it. Now pay attention, coming back to toxoplasmosis. Achha, you all I hope remember that in toxoplasmosis the infection is in the fetal life and it is reactivation of trophozoites in the adult life. Now pay attention, if it is a posterior uveitis in toxoplasmosis, this what is seen is that in posterior uveitis there is intense vitritis. Intense vitritis. Now due to intense vitritis, there are so many inflammatory cells here that when I am looking at the choroiditis patches, it seems as if I am looking through a fog, and this whole picture is called headlight in fog appearance. Headlight in fog, as if you are looking at a headlight through the fog. Okay, this was even your last year question. So make a nice double Q. It is a repeated question. So headlight in fog appearance is a feature of, you will answer. Sorry, you will answer. Yes, you will answer toxoplasmosis. So please make the figure. This is due to intense vitritis. You should always make all the rough figures that I am making, because when you look at the figure, you will always remember what we discussed in the class and you will learn better and retain better. And what about the treatment? Normally we are treating it with steroids, but in any uveitis, if you know the etiological agent, you have to treat accordingly. So for toxoplasmosis, you may give clindamycin. Okay. Next, give the heading syphilis. The next association is syphilis. Why I teach syphilis just after toxo? Because again it has the same presentation, either anterior or posterior, either granulomatous or non-granulomatous. Okay, either anterior or posterior, either granulomatous or non-granulomatous. Again, if it is a posterior uveitis, the posterior uveitis in syphilis can either be diffuse chorioretinitis, either it is a diffuse chorioretinitis or it is localized lesions, or it is a localized lesion. This diffuse chorioretinitis is what is called salt and pepper fundus. This is what is called salt and pepper fundus. Okay, this is what we have learnt in the first lecture, if you remember. And coming to localized choroiditis, this choroiditis patch is near the optic disc. This is called, so typically in syphilis, this choroiditis is near the optic disc. So this is also exam question, we call it juxtapapillary. Juxta means near, papillary means optic disc. So it's a juxtapapillary choroiditis. It's a juxtapapillary choroiditis. Okay, so both are exam questions. How will you treat it? Of course it is penicillin. We treat it with penicillin. Next association is tuberculosis. Tuberculosis. How will it present? It's a granulomatous panuveitis. It's a granulomatous panuveitis. Now coming to exam question, what is the most common ocular feature of tuberculosis? Most common ocular feature, please answer. Just now we have learned flectanular keratoconjunctivitis. It is flectanular keratoconjunctivitis. Treatment is ATT. Treatment is ATT. Okay, now we talk about next association is VKH syndrome. VKH syndrome. This is Vogt Koyanagi Harada. Vogt Koyanagi Harada syndrome. So what is the type of uveitis? Make a box and write. It's a granulomatous panuveitis. It's a granulomatous panuveitis. What is important asked in the exam is the systemic features. So coming to the systemic features. How does a patient of VKH presents? First is encephalitis. Encephalitis. Then vestibular dysfunction. Vestibular dysfunction. Next write down tinnitus. Tinnitus, ringing sensation in the ear. Alopecia, that is loss of hairs. Vitiligo, white patches on the skin. And one more very important feature, poliosis. Poliosis is graying of eyelashes. Graying of eyelashes. What was the exam question asked is, which uveitis is associated with encephalitis? So if they ask you this way, you will answer VKH syndrome. Which uveitis is associated with encephalitis? It is VKH syndrome. Next association is very, very important for exams, sympathetic ophthalmitis. Sympathetic ophthalmitis. Now sympathetic ophthalmitis, I think you all have got this idea. Injury is in one eye but uveitis occurs in the other eye. So first important thing is which injury. So which injury? It is perforating, always a perforating injury in one eye, write down. Perforating injury in one eye causing uveitis in the other eye. And therefore this uveitis of the other eye is called sympathetic ophthalmitis. So why is perforating injury in one eye causing uveitis in the other eye? Because of, write down, autoimmunity towards uveal tissue. There is an autoimmune reaction towards uveal tissue. What is the type of uveitis in sympathetic ophthalmitis? Make a box, all of you. It's a granulomatous panuveitis. Granulomatous panuveitis. Okay. If it is a granulomatous, you get nodules. And these nodules are not seen on the iris. This is exam question. These nodules are called Dalen Fuchs nodules. And let's see where they are. If this is the retina and this is the choroid. All of you please make the diagram. If this is the retina, this is the choroid. There is a membrane between the two. This is called Brooks membrane. So what is happening here? That the nodules are actually on the Brooks membrane. These are Dalen Fuchs nodules. So they are at the Brooks membrane. Another question they ask you. What is the first sign of sympathetic ophthalmitis? First sign of sympathetic ophthalmitis. You will answer retrolental flare. First sign is retrolental flare. Think yourself, I made in the diagram to show you that when we say retrolental flare, which area is involved? The ciliary body area, isn't it? Retrolental flare. So it should be just behind the lens, actually not extend so much, it should be just behind the lens. Or I'll make it again so that you all don't get wrong information. Just wait a minute, I am making the retrolental flare again. It is something. मनोज जो बाहर बोलना कि थोड़ा आवाज़ कम कर या दरवाज़ा बंद कर दो. Okay, so if this is the retrolental flare, okay, this is what I am showing you. So can you see it is the ciliary body area which is actually affected? So if it is the ciliary body area which is affected, what is the primary function of ciliary muscles? Accommodation. So if this question comes, what is the first symptom? It is related to accommodation. So first sign, retrolental flare, and first symptom is difficulty in near vision. You will answer difficulty in near vision. First symptom, difficulty in near vision. Okay, but everything will always first come in the injured eye. So this is a very important point here, but let's note down. There is another question related to what you asked. First let us note down this, that the first symptom you will answer is difficulty in near vision. I will come to it, just wait a minute, let me finish this. Or you can say decreased accommodation. But if this option is not given, then the second best option is photophobia. Then the second best option is photophobia. Okay? Now coming back to Bhatinda, your question. Sympathetic ophthalmitis will never develop before 2 weeks of the injury. Okay, so this is another question. So what is important is, it will never before 2 weeks. It never occurs before 2 weeks. So what is the ideal maximum chances of occurring? What is the duration is? Maximum chances are from 2 weeks to 3 months. Though there are cases where the sympathetic ophthalmitis has developed even after years. But what we will learn is not the rare case. Commonest presentation from 2 weeks to 3 months. What is most important? Never before 2 weeks. Please remember. So naturally everything will, in the other eye will occur only after 2 weeks. Okay? There's another question. What is the dangerous area of the eye? They have asked you. Which is the dangerous area of eye? You'll answer ciliary body. This is dangerous area of eye term has been given by Parson. So dangerous area of eye is ciliary body because any damage to the ciliary body will lead to sympathetic ophthalmitis. Okay. So this is the dangerous area of eye. So these are so many questions asked from sympathetic ophthalmitis. Right. Allahabad, what why? Explain, just please ask it nicely. Which why you are asking? Why before 2 weeks? That's what you are saying? Why not before 2 weeks? Dangerous area of the eye. Dangerous area of eye is ciliary body because, I am saying because whenever there is a trauma at the ciliary body, there is a very high chance of developing sympathetic ophthalmitis. Therefore, any trauma at the ciliary body is very high chance of developing a sympathetic. Yes. Okay. Good. So coming back to the next association after this sympathetic ophthalmitis is Fuchs heterochromic cyclitis. Fuchs heterochromic cyclitis. All of you know what is heterochromia iridis? Difference of iris color between the two eyes. Heterochromia iridis is. So this term itself, the name is telling that there is a difference of iris color. And if you remember, pay attention, I taught you what is atypical anti-uveitis. Any uveitis where the 5 fingers of the atypical, anti-uveitis features of 5 fingers, that is 5 features of uveitis are absent. So the one atypical anterior that we have already studied is JRA, and in the whole list we are going to study this second atypical, and this is heterochromic cyclitis. So let's learn the first point here is that it's an atypical anterior uveitis. It's an atypical anterior uveitis. It is unilateral and the eye in which the uveitis is there happening is eye of lighter color. So there is heterochromia iridis and the involved eye but Inda, the answer is that once first the injured eye is always first affected because आपके आँख में चोट लगेगी if you get any trauma in your eye, of course you will get the reaction first in the injured eye and then only in the sympathizing eye. I don't think there should be any confusion now. Okay. Then coming to heterochromia iridis is the next feature, and another very important feature because it is atypical anti-uveitis, no 5 fingers, there is no posterior synechia because it's a slow smoldering inflammation. There is no posterior synechia. Due to slow smoldering inflammation, there is no posterior synechia. Okay. So, thank you. What I said, another important point. Yeah, Guru, what a 3-point, ma'am. Okay, the 3 points, I'm repeating everything because we'll after this make a diagram and learn. What I'm saying, it's an atypical anterior uveitis. It is unilateral with heterochromia iridis, and when I say heterochromia iridis, the eye which is inflamed is always hypochromic. It has a lighter color compared to the other eye, and there is no posterior synechia. No posterior synechia. Okay. Now, what are the other features we will learn a diagram and learn? All of you make this diagram. It's my diagrams. These are all, no, you will not get in the book, but it's easy to learn things like this. And let's learn one by one. What are the other features of this heterochromic cyclitis? First, capes are star-shaped capes. They are stellate capes with feathery ends. So you will learn it as stellate capes. First point learn as stellate capes. Secondly, number 2, HI, right here, HI, that is heterochromia iridis. Number 3, write down here RI, rubeosis iridis. Then very important, right here, no posterior synechia. So with this diagram you will learn all the important features. And pay attention, how do you treat an this is an anterior uveitis, it's atypical anterior uveitis. And you have learned just now with me that with anterior uveitis you treat with topical steroids and topical cycloplegic. Now right here, because it is atypical, all of you write down here, no role of steroids and cycloplegic. No role of steroids and cycloplegic. Remember this. So the patient again will complain of will present with complications, and those complications this time we will learn only 2: complicated cataract, secondary glaucoma. So again all of you remember that band shaped keratopathy was common in JRA, not here. So here we will learn only 2 things: complicated cataract, secondary glaucoma. Now there is another very important exam question. Among the 2 atypical uveitis that you have just studied, that is JRA and heterochromic cyclitis, you have to answer that in which condition IOL implantation is contraindicated. You will answer JRA. IOL is contraindicated in JRA. That means patients of heterochromic cyclitis can tolerate the IOL much better. They tolerate the intraocular lens implantation nicely. Another very important question, again pay attention, because of rubeosis iridis in these patients, if this is the iris, above this is the cornea, due to rubeosis iridis, I am making the new vessels here in the iris, what happens is, if, pay attention, I will not repeat, pay attention, look up, if I am doing a paracentesis from one angle, matlab, if I am removing the aqueous from this quadrant, suppose from the inferior angle, any paracentesis from one angle causes bleeding from the opposite angle due to this rubeosis iridis, and this is called Amsler's sign. Now you can write it and make the figure. I give all the time. So paracentesis from one angle causes bleeding in the opposite, and this is called Amsler's sign. Okay, now we talk about another, I missed 1 or 2 important questions which I want to mention before I move further. There was an exam question last year, it was a neat NB style question, listen to the question. A young male presenting with recurrent anterior uveitis, okay, what is the most probable diagnosis? So a young male presenting with recurrent, let's write down, young male with recurrent anterior uveitis, most probable you will answer always arthritis. You should answer arthritis. Okay, come to the next question which I missed. You all know about heart therapy in HIV, highly active antiretroviral therapy. So the question asked is, if a patient is on a heart therapy, highly active antiretroviral therapy, what is the side effect of heart therapy in eye? What is the side effect of heart therapy in eye? Which arthritis? Which arthritis? It could be any. Mainly young males are, I have taught you all the types of arthritis that grow, it can be any arthritis. Okay. Coming back to heart therapy, the main side effect is uveitis. Why? Because when you start heart in an HIV patient, there is improvement in the immunity. Any improvement in immunity leads to immune recovery uveitis. This is called immune recovery uveitis. This was your last year exam question, guys. Okay, immune recovery uveitis. Done? Now what is the type of uveitis here? It is non-granulomatous and involving the posterior uvea. So mainly it is vitritis and posterior uveitis. Posterior uveitis is vitritis, we don't even need to mention separately. So it's a posterior uveitis. Agartala, what should I repeat? I couldn't understand the repeat. Okay, heart therapy I am saying that in heart, if you give a heart therapy to an HIV patient, this patient may start developing which common side effect in his eye? You will answer uveitis. Okay, okay. So this is immune recovery uveitis, and this type of uveitis is non-granulomatous, which is mainly a vitritis and posterior uveitis. Okay, next we talk about what is the next association. After this is onchocerciasis. Onchocerciasis, what are the points to remember? First of all, it is also called, we all know, river blindness, and I have told you it's not a disease of India. It is caused by Onchocerca volvulus. Onchocerca volvulus. Onchocerca volvulus, which is a nematode. It's a nematode. Then coming to what type of uveitis it causes, it is non-granulomatous, again either anterior or posterior. Either anterior or posterior. Next point, let's remember, it is included in Vision 2020. Included in Vision 2020. Next point is, how do you treat it? You should know the name of the drug. It is ivermectin. We treat it with ivermectin. Okay. Last association is ophthalmia nodosum. Last association is ophthalmia nodosum. So ophthalmia nodosum, this is nothing but intense granulomatous inflammation leading to a big nodule on the iris. Why does it occur is exam question. I repeat, intense granulomatous inflammation leading to a big nodule on the iris. Exam question, why does it occur? You will answer caterpillar hair in the eye. So this is what is asked. It is due to caterpillar hair in the eye. Okay. So that was about this chapter uveitis. Now we'll start with a very important chapter. I want all the attention from you all. Give the heading neuro-ophthalmology. Turn the page. On the fresh page, give the heading neuro-ophthalmology. We'll make this chapter very interesting and easy for you, and it's a personal advice to all of you. Please learn with me here itself. Let's start. What is the length of the optic nerve? I have taught you. It is 3.5 centimeters to 5.5 centimeters. And if I ask one value, you will answer 5 centimeters. So this is the length of the optic nerve. That is the first question that is asked. Then all of you make this diagram. Yes, Ludhiana, you're right. If this is the optic disc, this is the optic nerve which enters the optic canal, and then that goes into the brain. So this part where it crosses the three layers of the eyeball, this is your intraocular part. It is a very, very small part of 1 millimeter, intraocular part. Inside the orbit, this part is intraorbital part. Then when it enters the optic foramen, okay, let's talk first. What is optic canal? What is optic foramen? Both are same. If you remember your anatomy, when we learn the anatomy of the skull, the two orbits at the apex, there is a round opening at the apex of the orbit. That small round opening is called optic foramen, and that is synonymously used as optic canal. So this becomes the intracanalicular part of the optic nerve, intracanalicular part, and the part which goes into the brain, this becomes intracranial part, intracranial. So I repeat, there are four parts of the optic nerve: intraocular, orbital, intracranial, intracanalicular and intracranial. So intraocular, intraorbital, intracanalicular, intracranial. Pay attention, exam question, which is the longest part of the optic nerve? So many of you know it is intraorbital. The longest part, intraorbital. Next question, what is the length of the longest part? You will answer 25 to 30 millimeters. Length of the longest part, 25 to 30 millimeters. And which is the shortest part? I have already mentioned it, this intraocular is the shortest part, that is only 1 millimeter. This is the shortest part of the optic nerve, is intraocular. Okay, now let's come to the next diagram. If you are okay with this one, we come to the next diagram. We will be talking about optic canal, also called optic foramen. Question they ask you here, what are the structures passing through the optic foramen? So let's make, this is the optic foramen. There are only two structures. One is, you must have learned this diagram in your anatomy also. One is the optic nerve and second is your ophthalmic artery. So by this diagram we solve another exam question here. The two structures passing are ophthalmic artery and optic nerve. Done? Let's talk about the third diagram. Third diagram is about the superior orbital fissure. Superior orbital fissure. Fissure means gap. It's a gap between the roof and lateral wall of the orbit. And if you all remember this diagram, you have studied in anatomy that it is crossed by a tendinous ring which is called annulus of Zinn. This is called annulus of Zinn. Thank you. So this annulus of Zinn, what is annulus of Zinn? Sometimes this question is asked and you all generally answer wrong. Can you tell me what is annulus of Zinn? Or I will be more direct to you all. Which muscles are arising from annulus of Zinn? I want the answer. Waiting. Which muscles arise from annulus of Zinn? It's a tendinous ring from where? No answers? Allahabad, what did you answer? I couldn't get it. Please put on your caps lock and then answer me. I am more comfortable. Yes, very good. So you will too much of short form, huh? AR, huh? All rectus muscles. Very good. Many of you have answered correct. So not obliques but all recti muscles. Okay, Shimla, that was not only superior and inferior rectus Shimla, it is all recti. Yes, all the recti originate from annulus of Zinn. Now, you have to learn here. Yes, Hubli, you are right. What are the nerves which are passing outside the Zinn and what are the nerves passing inside the Zinn? So very easy, you must be knowing it also. We learn it with the mnemonic LFT. The mnemonic to learn is LFT. This is lacrimal, frontal and trochlear nerve. Trochlea is your fourth nerve. And what are the nerves passing inside the Zinn? 4 dots inside, 3 dots outside. Always remember this way. So what are the 4 dots inside? One is superior division of third nerve. Then this is your inferior division of third nerve. Then we have nasociliary nerve and abducens nerve. That is your sixth nerve. Abducens, that is your sixth nerve. Okay, all of you? So, please don't forget your LFT. So, once we are over with this diagram, this is all the question asked. Next is, you all must be remembering LR6SO4. You all know what is LR6SO4? यहाँ लग जाएगा क्या? So, LR is supplied by 6th and SO is supplied by 4th. So, what are the rest of the muscles supplied by which nerve? I know you all know it is the third nerve. So, please note down those muscles, it's important. Yes, it is the oculomotor Vishakhapatnam. So, superior rectus. You know it. नहीं आएगा इधर भी नहीं आएगा तो मनोज से बोलो कोई दूसरा चार्जर लगा medial rectus, inferior rectus and inferior oblique. So these are the muscles we are left with which are supplied by oculomotor. Okay. Now just now we have learned that oculomotor has two divisions, superior and inferior. So now note down the superior division. Okay, you learn like this, that both the inferiors are supplied by the inferior division of third nerve. Let's learn like this. Both the inferiors are supplied by the inferior division of third nerve and this is supplied by superior division of third nerve. Alright, thank you. Okay, now let us just give the heading optic neuritis. Optic neuritis. Okay, I want to know from you all, what is optic neuritis? It's important, that's why I am asking this question. Come on. All of you guys, what is optic neuritis? Don't be in too much of short form that I don't understand, okay? Yeah, what is optic neuritis? First. Waiting. Come on, what is optic neuritis? Lazy to write or what? Okay, Shimla. So you said it is optic disc inflammation. Okay, what? Not the nerve? What about optic nerve? Why are we calling it disc? Okay, Ludhiana, it is inflammation of optic nerve, right? Why? Because we are saying itis, and itis means inflammation. Okay, what did you say? Achha, Vishakhapatnam says. Okay, now I would like to correct you all. And if we correct each other, we learn better. That is why I wanted you all to answer, so that you will always remember what I said. See, optic neuritis, though the term seems to be inflammation of optic nerve, we will not learn like this. We will learn optic neuritis is optic nerve disease. Why? Because any optic neuritis can be inflammatory, degenerative, autoimmune, it can be ischemic, and so on. So it's not always inflammation. No, it is not always inflammation. So what is optic neuritis? Write down, it's an optic nerve disease. It is nothing but an optic nerve disease. And you all know what is the function of optic nerve? To carry the impulse from the eyeball to the brain. So this is what is hampered. You see your first diagram? Optic nerve क्या कर रहा है? It is taking the impulse from the eyeball to the brain, and that impulse transmission is hampered. This is optic neuritis. Let's note down, all of you write down please. Write down. What is optic neuritis? It's an optic nerve disease, and let's now define it. It is a pathological condition of the optic nerve. It's a pathological condition of optic nerve where nerve impulse transmission is hampered. Where the nerve impulse transmission is hampered. Okay. Next we talk about is, Mysore, what are you asking? Consider your question again please first. Okay. Now we talk about what are the clinical features of optic neuritis. What are the clinical features? So what we are learning here, that when the optic nerve is not feeling well, when the optic nerve is diseased, what are the symptoms and signs the patient will have? So again we will learn the 5 fingers. First is decreased visual acuity. First is decreased visual acuity. Second, visual field effects. Visual field effects. Tell me what would be the, when you talk about visual field effect, we are talking about scotomas. So what are the different scotomas? What type of scotoma you get if there is an optic nerve lesion? It is always central scotoma. Okay, so you will answer it's a central scotoma. Right. Now we talk about next is, third is afferent pupillary defect. All of you pay attention and look at me. First, listen to me, I will give you all the time to write. What do you mean by afferent pupillary defect? When I show light to your eye, what happens? Your pupil constricts. This is your light reflex. Now, if in any patient, either the pupil is not constricting at all, or after constriction immediately it starts dilating. That means it is not sustaining, it immediately starts dilating. All these abnormalities are called afferent pupillary defect. Okay. So you can just understand anything away from the normal light reflects. Third is this. Fourth is the eye with optic neuritis. There will be less of the color, it will appreciate less color, decreased color, and there is decreased brightness. Decreased color, decreased brightness. Okay, so these are the 5 fingers of optic neuritis. Pay attention all of you. The question is, what is the first sign of optic nerve disease? So among the 5, which is the first sign of optic nerve disease? You will answer APD. So the first sign of optic nerve disease is afferent pupillary defect. It is afferent pupillary defect. Okay. Now we talk about the classification of optic neuritis. How do you classify optic neuritis? We classify optic neuritis, either we do it anatomically or we can go etiologically. Now etiologically I just told you what are the different types of optic neuritis. Let us enumerate the list. It can be inflammatory. Number 2, degenerative. Third, write down autoimmune. Ischemic and hereditary. Ischemic and hereditary. So these are the 5 types of optic neuritis. Talking about anatomy. Anatomically, let's take the next page. We have to write a lot on that. So anatomically, any optic neuritis can either be a papillitis. I told you papilla means optic disc. So when you say papillitis, of course it's optic neuritis, so all the 5 fingers are present in all. But in papillitis, disc is involved. So you get a blurred disc margin on fundus examination. Second type is retrobulbar neuritis. Retro means behind, bulbar means eyeball. So retrobulbar neuritis means the part of the nerve involved is behind the eyeball. That is, fundus, when I look at, it is absolutely normal. So here in retrobulbar neuritis, fundus is normal. And the third type is neuroretinitis. It is neuroretinitis. Again the name is telling you, nerve involvement, retina involvement. So you get a papillitis and the pathology is spilling in the retina. Again, time to listen first before we write. Listen. When the pathology is spilling in the retina, there is increased capillary permeability in the retina, leakage of water, leakage of lipids. Leaked lipids are what we call hard exudates, and these hard exudates are arranged radially on the macula. Therefore, we call it macular star. Okay. So, this is what you have learnt in your book. Neuroretinitis is papillitis with macular star. So, what is papillitis with macular star exactly? Macular star is leakage of hard exudates, which are lipids arranged radially. Okay. Coming back to retrobulbar neuritis, very important. There are two pathognomic features of retrobulbar neuritis. Both are exam questions. First is RAPD, which means relative afferent pupillary defect. Now what do you mean by RAPD here? Let's understand. Pay attention all of you. Look up, look at me. See, when you are looking at the light reflex of the patient, at one go you get a normal reaction in both eyes. Okay. Now you start comparing both the eyes. Suppose this is my torchlight and I am comparing the two eyes, the light reflex reaction in both the eyes like this. So keep listening. So what happens? Suppose I get a constriction. Okay, this is normal. Constriction. ठीक है. Constriction, 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 dilatation. So by comparing again and again, at one point with a direct light I am getting dilatation, which is absolutely abnormal. To get a dilatation with a direct light is something very abnormal. So this is called RAPD, relative APD. Why? Because I am able to catch hold of this problem only when I compare it with the other eye. So when I am comparing, I am exhausting the pathway and so I am able to catch hold of this problem. So I call it relative afferent pupillary defect. So we call it relative afferent pupillary defect. Okay. Then we talk about this relative afferent pupillary defect is also called Marcus gun pupil. We also call it Marcus gun pupil. And you have to learn 2 points in this, that is ours in the exam. In which condition you get it? R for R, retrobulbar neuritis. And the second question they ask you is, which test you do to diagnose this? It is swinging flashlight test. I am swinging the flashlight from one eye to another. So it's a swinging flashlight test. So these are the 2 questions asked. Okay. Next we talk about is what is the second pathognomic feature of retrobulbar neuritis? What is the second pathognomic feature? It is pain on eye elevation. Pain on eye elevation. Okay. So pain on eye elevation, why will it occur? In a patient of retro, let's understand, all of you look up. See, the superior rectus fibers from the annulus of Zinn originating here are inserting on the eyeball. Now it's a normal anatomy that some fibers are attached to the myelin sheath of the optic nerve. Therefore, when you ask the patient to look right, nothing will happen. To the left, nothing will happen. But when you ask the patient to look up, the superior rectus fibers contract. They pull on the nerve and patient has pain. So if they ask you, this is again exam question, that pain on eye elevation occurs due to, you will answer it occurs due to superior rectus fibers. So pain on eye elevation occurs due to superior rectus fibers. Okay, next we talk about let's take one by one. First is inflammatory optic neuritis. Now we go again back to the etiological classification. First one is inflammatory optic neuritis. What will be the example? We have just learned the chapter of uveitis. Think yourself, I told you that whenever there is choroiditis, there is also papillitis. So that is what is inflammatory optic neuritis. So you will just note down, in inflammatory optic neuritis, it is all causes of posterior uveitis. All the causes of posterior uveitis. Okay. What is next? What have you written, Ludhiana? Mysore, what are you asking? Any? Okay. Okay, we'll talk about that. Let's concentrate on this chapter first. Ludhiana, I don't get it. What do you mean by that? Inflammatory optic neuritis is all the cause of posterior uveitis. Second is degenerative. Degenerative. Degenerative optic neuritis. First very important example is very important topic of your medicine, multiple sclerosis. It is multiple sclerosis. And what about the second? Second very important example is toxic amblyopia. Toxic amblyopia. So we all know this is very important for exams. We all know toxic means due to drug. So think yourself, the patient is eating the drug, getting a partial loss of vision, that is amblyopia. And why it is happening? Due to degenerative optic neuritis. So correlate that in your mind. What are these drugs? First and foremost, tobacco. First and foremost is tobacco. Second, ethambutol, which is an ATT drug, ethambutol. What next? Chloroquine. Then ethyl alcohol, and finally methyl alcohol. Methyl alcohol. Okay, so these are the different drugs which cause toxic amblyopia. What are the questions asked? Why I said it is important? Let's understand. First question they ask you is, what is the field effect in tobacco amblyopia? Think yourself, listen to me first before answering. Field effect in tobacco amblyopia. So tobacco amblyopia is what? Degenerative optic neuritis. And so what will be the field effect? Now answer me. What should be the field effect in tobacco amblyopia? I just said tobacco amblyopia is nothing but degenerative optic neuritis. So what is the field effect? Very good, Ludhiana. It is central scotoma. And what have you written before? I could not still understand. I am trying to. Anyway, it is central scotoma. Anybody else? Can you specify which central scotoma? Why are they asking you for tobacco only? Pay attention. Very good, Ambala. It is centrocecal. So a type of central scotoma. First listen, I will give you the time to write. If this is the blind spot, this is the macula. The central scotoma which touches one end at the blind spot, one end at the macula. This one is called, make the figure all of you, centrocecal scotoma. So it is a type of central scotoma. If this is given in the option, you will first mark this as the answer. If it is not given, then we mark central scotoma. Then we can mark central scotoma. What is the next question they ask you? They ask you which is more dangerous, ethyl alcohol or methyl alcohol? I know you all know this. You will answer methyl alcohol. Now my question is, why methyl is more dangerous? This was also recently asked in the exam. Answer me, why is methyl more dangerous? Come on, why is methyl alcohol more dangerous? Okay, Alabad, no. Actually, formaldehyde formation and all this is just a mechanism of action, isn't it? Why it is more dangerous? Acute damage. Okay, Ambala, but why will there be an acute damage? Let's understand. Methyl alcohol directly damages the ganglion cells. So in no time the patient will develop optic atrophy. Okay. This is the reason it is so dangerous. Whereas what about ethyl alcohol? Ethyl alcohol is a chronic damage. Ethyl alcohol is a chronic damage. When a person is only drinking, he is not eating anything, this will lead to chronically, if he is only drinking, it will cause vitamin B12 deficiency. And due to vitamin B12 deficiency, he is going to develop, due to vitamin B12 deficiency, he will develop optic neuritis. Okay? Therefore, how do you treat it? You give hydroxycobalamin injections. We give hydroxycobalamin injections. Okay, so that was about this question. Now come to the next question. What are the other ocular effects of chloroquine in eye? What are the other ocular effects of chloroquine in eye? One you have learnt in my first lecture was posterior subcapsular cataract, if you remember. Second I am telling you is optic neuritis. Now we are left with third and fourth. Third, very important question, bull's eye maculopathy. Which retinopathy you have to be? You have to Shimla, you have to first specify it is bull's eye maculopathy. What is bull's eye maculopathy? Bull's eye maculopathy means at the macula there is alternate area of, suppose this is the disc, at the macula there is alternate area of hyper and hypopigmentation which looks like an eye of a bull. So, this hyper and hypopigmentation is what is called, yes Shimla, it is called bull's eye maculopathy. Okay. There was another question which had confused you all. Does hydroxychloroquine also cause bullseye? Yes. Chloroquine, hydroxychloroquine, both will cause bullseye maculopathy. Next we talk about is, okay, I'm slow. What is the fourth effect, Jammu? What is the fourth effect of chloroquine in eye? Write down. It is, should I repeat anything? Okay, I'll repeat. What I said is chloroquine has four effects in the eye: posterior subcapsular cataract, optic neuritis, bull's eye maculopathy. And I said that bull's eye maculopathy is alternate area of hyper and hypopigmentation at the macula. What else? Vortex keratopathy. Okay, vortex keratopathy. Vortex keratopathy is, vortex keratopathy, Hubli, I hope it's comfortable now, is deposition of chloroquine on the cornea in a whirl-like manner like this. This is whirl-like manner. From central point at radius, this is called whirl-like manner. So, deposition of chloroquine on the cornea, this is vortex keratopathy. Okay? So, these are the effects of chloroquine. Now, let us learn what are the other causes of vortex keratopathy. Before I move further, what are the other causes of vortex keratopathy? Very important, amiodarone. Amiodarone. Tamoxifen. Fabry's disease. Okay, did I mention to you all in my first lecture that what about Kayser-Fleischer ring? Answer me, did I tell you whether it is reversible or irreversible? Tell me all of you, Kayser-Fleischer ring is reversible or irreversible? Fast. Case of flesh ring is reversible or irreversible? Okay, let's learn. Case of flesh ring is always irreversible. Yeah, it's irreversible, I think I told you all. Only it will fade out, it will never go. But when we talk of vortex keratopathy, it is reversible. Just remember this. Vortex keratopathy, stop the drug, it will go. So, vortex keratopathy is innocuous and it is reversible. Okay? Now we talk about what is the next type of optic neuritis is autoimmune optic neuritis. Autoimmune optic neuritis means optic neuritis in connective tissue disorders. Optic neuritis in connective tissue disorders. Now we come to ischemic. The next important is ischemic optic neuritis. Now ischemic optic neuritis is also called AION. AION stands for anterior ischemic optic neuropathy. Anterior ischemic optic neuropathy. So when you say ischemia, which arteries are blocked which affects the optic nerve? Come on, answer me. Ischemia is due to blockage of which artery? Okay, no, it is not central retinal artery. Okay, I think Ludhiana is correct. So it's not said. Let's ophthalmic Dhule. It will never be ophthalmic. Main artery is ophthalmic. Mysore, I think your question is also slowly being answered. That the main arterial supply to the eye is ophthalmic, and there has to be some branch of ophthalmic which is supplying the sclera, and the branches which are supplying the uveal tissue are ciliary arteries. So now I am asking the question again. My question was which artery is blocked so that the patient suffers from ischemic neuropathy. To understand that, please remember one thing, that retina has 10 layers, right? Now the outer 4 layers of the retina, if this is the choroid, the iris, the ciliary body, this is the iris, ciliary body and choroid, and this dotted line is the retina. All of you make the figure, let us understand. The main artery supplying the eye, as we learnt, is this one is your ophthalmic artery, which is passing through the optic foramen, entering the eye like this. This one is ophthalmic artery. Now this ophthalmic artery gives branches to the uveal tissue which are called ciliary arteries. Okay. So let's learn what is the blood supply. Write down ciliary arteries are of two types. They can be anterior or posterior. Okay. Anterior are muscular branches. Now this was asked in your exam. Anterior are muscular branches, and the posterior ciliary can again be long and short. Long are only 2 in number, and how many are short ciliary? Again this was exam question. Short posterior ciliary can range from 10 to 20 in number. It can range from 10 to 20 in number. Okay, coming back to this diagram, let us understand now. Pay attention, it is very easy, it is not difficult. Artery, I said, supplying this part, choroid, ciliary body and iris is ciliary artery. Now the posterior ciliary artery can be long and short. The short are many, and these short posterior ciliary are the ones which are supplying the choroid. Whereas the long posterior ciliary will go anteriorly, one from here, one from here. Okay, two long posterior ciliary. I am going very slow, so don't ask me to repeat, I will not. So pay attention. Ciliary artery from the ophthalmic supplies the uveal tissue. Short posterior ciliary, which are 10 to 20 in number, they will supply the choroid. The long posterior ciliary travel anteriorly. Anteriorly, at the base of the iris, they are anastomosing with anterior ciliary. This is the posterior, this is anterior. At the base of iris, what are anterior? They are muscular branches, if you remember, and this is the posterior. This anastomosis at the base of iris between the long posterior and anterior is called major arterial circle. Okay, between the long posterior ciliary and anterior, this is major arterial circle. Now arteries from the major arterial circle travel here and here, and at the pupillary border they form the minor arterial circle. Okay, let me show you in this diagram this will be more clear to you. I said if this is the iris, then arteries at the base of the iris, there is one anastomosis at the base of the iris. This is your major arterial circle. This one is the major arterial circle. And then arteries from this arterial circle are arising and anastomosing at the pupillary border. This one is called minor arterial circle. Got it? Now coming back to this one, I have still not explained about optic neuropathy, so let's now explain about optic neuropathy. This was just the blood supply of the uveal tissue. I thought I'll teach you this also. Now pay attention. I said retina has 10 layers. Outer 4 layer of the retina is supplied by the same arteries which are supplying the choroid. That is short posterior ciliary arteries. Okay. And when you say central retinal artery is a separate branch I am drawing here from the ophthalmic, and it supplies the inner 6 layers of the retina. This one is your central retinal artery. Okay. So, central retinal artery is supplying the inner 6 layers, and the outer 4 layers are supplied by the choroidal arteries, which are short posterior ciliary arteries. Short posterior ciliary arteries. Okay, so now pay attention. Optic neuropathy ischemic is due to blockage of short posterior ciliary. So anterior ischemic optic neuropathy is due to blockage of short posterior ciliary arteries. This AION is of two types, arteritic and non-arteritic. Arteritic means the blockage of short PCA is due to giant cell arteritis. It is due to giant cell arteritis. Okay, and giant cell arteritis is a very important topic of your medicine. Make an HW and learn it. Revise it from your medicine. Coming to non-arteritic, the cause we do not know, but the major risk factor is hypertension. Again, I need all the attention here. Pay attention, listen first. Why will a hypertensive patient suffer from ischemia? The theory says in a case of a long-standing hypertension, the patient may be suffering from nocturnal hypotension. At night the pressure is less, and due to nocturnal hypotension there is AION, ischemic optic neuropathy. Okay, so that was the cause. Coming to features, we will learn two features in each. First feature of arthritic is sudden painful diminution of vision. So it's a painful diminution of vision. Visual acuity is markedly reduced. It is a sudden painful diminution of vision, and visual acuity is markedly reduced. Whereas if we talk about non-arthritic, it is sudden again but painless diminution of vision. And painless diminution of vision, this time the visual acuity is slightly reduced. It is just slightly reduced. Second feature of arthritic is amaurosis fugax. I taught you it is transient loss of vision. Amaurosis fugax is a transient loss of vision. And second feature of this condition, that is non-arthritic, is a very important exam question. Write down altitudinal field effect. Altitudinal field effect. I'll explain you, just note down first. Altitudinal field effect. Now what do you mean by that is, normally you learn the field effects like this. Nasal is gone or temporal is gone. Altitudinal means superior gaya या inferior gaya. Either superior field is gone or inferior. This is your altitudinal field effect. Make the diagram, all of you. On examination, whether it is arthritic or non-arthritic, what you get, whether it is arthritic or non-arthritic, you get blurring of the disc margin, blurred disc margin due to neuritis, and hemorrhage below the disc, flame shaped hemorrhages below the disc. So in both the cases the picture is same, blurred disc margin and flame shaped hemorrhage below the disc. Talking about treatment is also the same, whether arthritic or non-arthritic. We first start with IV steroids for 4 to 5 days, followed by oral steroids. I repeat, treatment in either case is the same. We give IV steroids followed by oral steroids. Pay attention, if you only give oral steroid, the patient will not respond. So IV is very, very important. Only giving oral, the patient will not respond. Okay, but Linda, I just said that in both the cases, treatment is same, that is IV steroids followed by oral steroids. IV steroids is given for 4 to 5 days and that is followed by oral steroids. And what I said, Batinda, that if we only give oral, not giving IV, the patient will not respond. That's what I just said. If we only give oral, patient will not respond. Okay. Next is your hereditary optic neuropathy. Hereditary optic neuropathy. Allhabad, altitudinal field effect, let's solve this. Altitudinal field effect means the patient's, if this is the patient's field, either the whole of superior is gone or whole of inferior is gone. Normally, if you remember your field effects, you have learned something like this. Bitemporal hemianopias, what are they? When temporal, so either nasal goes or temporal goes. This is what you have learned. But altitudinal is this type of field effect. This is called altitudinal. Have I answered you, Allhabad? This is what is altitudinal field effect. Good. Now we talk about hereditary optic neuropathy. It is also called Leber's hereditary optic neuropathy. Leber's hereditary optic neuropathy. So, where is the mutation? This is exam question. It's a genetic disease. Mutation is at, remember 2 M's, maternal mitochondrial DNA. So, it is at the maternal mitochondrial DNA. Okay, don't forget maternal. On clinical feature, the patient will present with optic neuritis in one eye, followed by optic neuritis in the other. Later, there is atrophy in one eye, followed by atrophy in other. So, you can't prevent this blindness. We cannot prevent this blindness. Okay, next we talk about is that though it is an optic neuritis, what do you want to repeat, Bikaner? I am so slow. I just said that the mutation is at maternal mitochondrial DNA. Patient has neuritis in one eye, followed by another, then optic atrophy in one eye, followed by atrophy in the other eye. Okay, this is hereditary optic neuropathy. We cannot prevent the blindness, it is genetically controlled. Very, very important, pay attention. Though it is an optic neuritis, there is no APD. We do not know why, but pupillary reactions are normal in these patients. Pupillary reactions are normal in these patients. Okay, next we talk about on examination, sometimes in these patients what you see is telangiectatic vessels on the disc. Dilated capillaries are seen on the disc. So, what I see is telangiectatic vessels on the disc. Okay, no effective treatment. Write down no effective treatment. Talking about next is papilledema. Okay, papilledema. I think it's better if we continue tomorrow fresh with a fresh mind. It's an important chapter. I'm in no mood to take the class till 9 o'clock. We can end it here. Any questions? I'll wait for another 5 minutes. If you want to ask something, please ask. Rest we will continue with the neuro-ophthalmology tomorrow. Yeah, great. Many of you are very happy because when you are tired, you can't cover such an important chapter. I want you all to be in time and be fresh tomorrow. Let's study neuro-ophthalmology and continue then, okay?